Okay, I think we'll go ahead and get started. This is the Oregon Health Policy Board, July 10th, 2018, slightly after 8:30. We have a full agenda today, full of CCO 2.0, no surprise. Let's see, in a minute we'll look at our minutes from the last meeting, review the calendar. We've got public testimony, and I know we've got some folks signed up. If there are other people, you can sign up at the staff table. Pat is running a few minutes late, but we'll have a report for us, and if not, I'm sure Jeremy can riff in his stead, and then we'll hear more directly from Jeremy and Steph as we dive into the CCO 2.0 work for the rest of our meeting. So that's what we've got. I will say our intent is to have a set of recommendations that we can take action on in terms of CCO 2.0 at our October meeting. So we'll review in August, we'll review again and refine in September, and then in October we'll actually take action. Currently, we're talking about having that October meeting in Hood River, although just for the fun of it. I just said to staff, why not Lake County? So staff is going to look for options on the east side so that we can get into House District 2. But just to let you all know, if you've got thoughts and considerations about travel, you should let staff know, and they'll factor that in as they're looking for a spot for us in October.
Or a bike ride is that?
You can do it. You might want to start now. So what else? The metrics report and the hospital transformation performance report reports are both available and have been sent out to board members, so you should have those available. The metrics have been reported this time for the first time in by language as well as race and ethnicity when and where that was possible. And next month, in addition to this kind of intensive CCO 2.0 look, we'll also have there's a high-cost drugs agenda item that we'll be talking about, getting an update on. As a part of the CCO 2.0 process, we're also looking for a date for a health policy board CCO leadership joint public meeting. You guys should have gotten an email from Jeremy asking to check calendars because we'd really like to try to get as many folks there as possible. So that's great. And then the last kind of announcement that I would make is just an acknowledgement. I think I may have mentioned this previously, but if not, I wanted to make sure to say it publicly. That Karen Joplin has left the board for personal reasons. So I just wanted to thank her for the years of service that she put in and acknowledge that means we have one additional board seat available. It currently puts us at 2. And outside of some strong arming, that will go to 3 in the not too distant future. If you are interested in the Health Policy Board, you can go to our website and find out more, and that's also a place where you can get to the application process with the governor's office.
Zika, just to add on that piece, there is in statute a 4-person cap in terms of folks who either derive any household income from healthcare or are on a state public health plan, and we're still at that cap. So, looking for folks who don't have household income from healthcare who are interested in joining the board.
Thank you for that. And we also need a working physician, which luckily we have one. Maybe 2, but I think 1.
I work and ask for this.
That's what I thought.
And they don't actually have to be a physician.
Right.
They are a healthcare provider.
Why, thank you.
Oh, yeah.
Yeah.
Good clarification. Okay, great. So we have the minutes in our packet from the last meeting. I do know that we're going to be adding a small section on the conversation we had with the Health Plan Quality Metrics Committee. So that'll be in addition. Does anybody want to make a motion about our minutes? With
Motion
the-
to approve?
Great. Is there a second?
Second.
I would assume that's a motion with the amendment of the additional information. Great. Any discussion? Everybody's name is spelled right? Great. All those in favor of accepting the minutes as they are?
Aye.
Aye.
With the amendment. Any opposition?
I wasn't here last time, so I'm going to abstain.
Okay. How does Robert's Rules of Order deal with that?
I think we.
I think we need a quorum. So
Hey, Zeke, I'm here. John
Sweet.
Fanta.
Yeah.
John is in the house. John, how do you feel about those minutes?
I'm just fine with them.
Great. I believe we have a quorum, the vote of 5-0 and 1 abstention. Thanks, John. Make sure to chime in anytime you feel necessary along the way. So
Okay,
good to
thanks.
know you're there. Great. And then we've got our long-term calendar. A lot about, let's see, we're on the bottom of the second page currently. A lot about our 2.0 process through October. Again, the acknowledgement that we will likely be somewhere out of area in our October meeting. Couple of reports that are both coming to us and that are either OHA or OHPB has some responsibility to move forward. Any questions or thoughts about the calendar? It occurred to me that kind of post-October, we're going to have a rash of different things that'll probably be coming to us that are kind of non-CCO 2.0 related, but pretty critical. And you can see some of those in terms of reports from the committees that have been working on other work as well. Excellent. Great. We can move forward. Jeremy, means that, oh, actually, we got public testimony. So public testimony, we did at the beginning of our meeting. Thank you for those who have signed up. I'll call you up in a moment. Just a reminder, we ask you to keep your comments to 3 minutes or less. I will give you a sign when you have about a minute left, and then I'll stare at you even more intently when you've reached the end of your time. And if you continue, I may actually just ask you to wrap it up. We're fairly informal, but have a lot on the agenda, so I want to get through it. But so I'll call the first two up. That's Montana Gay from OHPB and Iris Bixler from, I think it's Cornerstone. Great, and you guys can come up and speak in whatever order you want. And as I said, I'll let you know when you're getting close.
Do you want me to go first? It doesn't matter. Okay. All right. Am I good to go?
You're good to go.
Perfect. So Chair Smith and members of the board, thank you for the opportunity to provide recommendations on behalf of community health workers in Oregon. My name is Montana Gay, and I represent OHPB, the Oregon Community Health Workers Association. OHPB works to provide a unified voice for community health workers throughout Oregon. And over the last few years, community health workers have developed a collaborative relationship with CCOs. While there are many aspects of the current CCO model we applaud, there are some areas surrounding payment and utilization that could benefit from adjustment and ensure CHWs are implemented effectively in the system. First, OHPB recommends that CCO 2.0 incorporate a more effective and sustainable payment system for CHWs. There are a variety of payment models to research when developing, so we ask that ongoing collaboration between OHPB and the Oregon Health Policy Board be present throughout this planning process. If value-based payment systems are established for CHW payment, we ask that they not be contingent upon short-term member health outcomes. And the reason why we ask this is because CHWs often address social determinants of health, which are difficult to analyze in the short-term measurements and will misrepresent the impact the CHWs have if selected as a value measurement. We also recommend the board look to develop a CHW utilization plan for CCOs. OHPB workforce data demonstrates that CHW turnover rates are high due to limited systemic support and improper usage of CHWs. The incorporation of utilization plan will not only increase retention of CHWs, but also break down the discussed barriers and require CCOs to use CHWs at the top of their certification. We recommend the utilization plan be developed in collaboration with OHPB and include definitions of CHWs in their scope of practice, as well as a clear list of deliverables that, if met, demonstrate effective usage of CHWs at the top of their certification. We also ask that this utilization plan incorporate a 5-year trajectory plan to provide a clear outline for the usage of CHWs and CCOs. Lastly, OHPB strongly encourages you to support all recommendations made by the Traditional Health Worker Commission. In particular, we are confident that their suggestion to increase support for community-based organizations, or CBOs, will help improve overall health in Oregon. CBOs are valuable organizations that provide comprehensive support by addressing the social determinants of health, which is extremely important to CCO 2.0. CBOs often provide this community-centered support through the use of trained CHWs. And with increased support and financial investment in CBOs, we will also see better utilization of CHWs. We thank you for the opportunity to provide public testimony, and we'll be sending in our written statement to provide a more comprehensive overview of our recommendations. Thank you for your time.
Thank you.
Good morning.
Morning.
My name is Iris Bixler, and I'm the Traditional Health Worker Program Supervisor for Cornerstone Community Housing, an affordable housing provider based in Eugene. As a certified community health worker for 2 years and a certified doula for almost 23, I want to share my perspective, which draws on my years of experience working with low-income and marginalized communities. We are all becoming increasingly aware of the importance that housing has on health, and in particular, how stable, affordable housing affects the social determinants of health. I encourage you all to look further into engaging with affordable housing systems to achieve your long-term public health goals. As housing providers, we have a unique opportunity to provide front-door access to populations that have historically been underserved and overlooked. One of the ways that health systems can get involved in serving affordable housing communities is through the engagement of traditional health workers. As a refresher, a traditional health worker is an umbrella term for 5 specific worker types: community health worker, peer support specialist, peer wellness specialist, patient navigator, and doula. By definition, traditional health workers have lived experience and are from the communities in which they serve, thus giving them an exclusive insight into what specific needs are in their own community. By embedding traditional health workers in affordable housing or other systems of care, you are providing trauma-informed support that leads to better health equity. In addition, studies have shown that using traditional health workers benefits the healthcare system by reducing healthcare costs, increasing patient engagement, and improving health outcomes. Engaging traditional health workers in behavioral health, physical health, affordable housing, and early learning systems creates a collaborative infrastructure that allows us to reach outside of our own silos to accomplish shared goals and align strategies. As a member of the Traditional Health Worker Commission's Payment Model Subcommittee, I would like to also urge this board to look closely at sustainable payment mechanisms. While in theory, the state's legislation that created the Traditional Health Worker Registry allows for traditional health workers to bill Medicaid, the reality is that OHA, CCOs, and community-based organizations are not all on the same page with contracting, credentialing, and billing. I hope that you look closely at the recommendations coming from the Commission around this issue. Additionally, I would also bring to your attention the Commission's recent recommendation to fund a full-time OHA staff person who could provide technical assistance to CCOs and CBOs regarding traditional health workers. To wrap up and reiterate, it is my deeply held belief that a key to reducing healthcare costs, providing better care to OHP members, and balancing persisting health inequities is the utilization of traditional health workers.
Great, thank you. Thank you both. You're free to go. Thanks for coming all the way as well.
Yes, you're welcome.
Iris. Next, I'll call up Linda Jaramillo from the Oregon Latino Health Coalition and Jorge Gutierrez from the Lower Columbia Hispanic Council. You have a tough, that was a tough group to follow because they were right in their timing.
We'll do our best.
Okay, great.
Good morning, and thank you for this opportunity to give testimony. My name is Linda Jaramillo, and I'm the Interim Executive Director of the Oregon Latino Health Coalition. It is in my capacity as the interim director to be also serve as the co-chair of the SB 558 External Stakeholder Work Group. As you, I hope, know, that just on Sunday we celebrated a whole 1-year anniversary of the passage of SB 558, we fondly know as Cover All Kids. The Oregon Latino Health Coalition is proud to have played a significant role in the monumental public policy that provides health care access to all Oregon's children and teens, regardless of immigration status. The SB 558 External Stakeholder Group was formed in the fall of 2017 as a key provision of the bill for the purpose of advising OHA, and currently now DHS, on culturally and linguistically responsive outreach and marketing strategies to encourage OHP enrollment by the SB 558 population. It has proven to be a very positive and productive relationship between and among state partners and community-based organizations. I commend those who recognize the importance of such collaboration because it has proven to be an essential piece for implementation of SB 558. As a former state program manager myself and longtime community activist and advocate, I can personally and professionally attest that this type of partnership is vital to successful implementation of public policy. While state leaders are committed to addressing the health access challenges faced by Oregonians, I'm sure you'll agree that community partners are in the best position to identify the barriers and work with the community members to solve these problems. In our case, as a culturally specific organization, our commitment is to build and maintain trusted working relationships with our community. And in so doing, we build the bridges that will result in the elimination of health disparities affecting Oregon's Latinos and Latinas, getting us closer to our vision that we too can experience the fullness of community wellness. My colleague Jorge Gutierrez, also a member of the stakeholder group, will share some specific experiences that our communities have had when seeking to enroll in OHP programs and get access to health care through the CCOs. Thank you so much.
Thank you.
Good morning. My name is Jorge Gutierrez. I'm the Executive Director of the Lower Columbia Hispanic Council in Astoria, and I'm also a member of the SB 558 External Stakeholder Work Group. As a funded community partner through DHS's Community Outreach Partner Program, our organization has been intimately involved in conducting OHP education, outreach, and enrollment activities related to SB 558 in Clatsop, Tillamook, and Columbia counties. Through this work, our staff has built strong relationships with community members, and in the process have discovered that community members often face cultural and linguistic barriers relating to the OHP application process, as well as with communication and general navigation of both the OHP and CCO systems. For example, during the OHP application process, when Spanish-speaking members call the OHP call center to obtain updates on their case, they often don't get connected to a Spanish-speaking operator, despite selecting the Spanish language option in the main menu. We have found that this is also a common problem when a member directly calls the CCO and requests to speak to a Spanish operator. With written communication, we have found that when OHP sends out letters, such as to request additional information or to notify of an upcoming renewal, the letters are often sent in English despite the member having requested to receive material in Spanish. Once enrolled into their CCO, some members have reported receiving welcome packets in English despite selecting Spanish as their preferred language. Members also frequently report that they did not receive their ID cards from the CCO. This creates access problems when they are asked to show their CCO ID card at medical appointments. While our CCO has instructions on their website explaining how to request a new card, many of the members we work with are not computer literate. Additionally, calling the CCO to obtain a new card can be difficult because, as mentioned previously, calls are picked up by English-speaking operators despite selecting the Spanish language option. While these are only a few examples of the cultural and language barriers that we have encountered, it is important to point out the effects that they have on families. In most cases, it results in a delay in enrolling in OHP, and in some cases, a delay in accessing medical treatment. Through participation in this work group, we have found that these incidents are not unique to the rural North Coast community that my organization serves, but that they are barriers commonly faced by other communities throughout the state. Despite the barriers, we have found some encouraging results. In particular, as a work group, we have discovered the important role that community-based organizations can play when partnering with our OHP and CCO systems to address cultural and linguistic barriers. The work being done as a result of SB 558 should be looked at as possible model for future health investments into our communities. With CCO 2.0 in the planning stages, I believe now is a good time to support investments in these types of collaborative partnerships as a way to create health systems that are culturally responsive, accessible, and equitable for all Oregonians. Thank you.
Thank you.
Thanks.
Thank you, Jorge, thanks for making the drive, and thanks all four of you for the work that you're doing, and really appreciated hearing from the community perspectives, both on CCO 2.0 and on the work of the external advisory group. Really helpful at this moment in time. Is there any other public testimony at the moment?
Great. Follow up on Felicia's comment. It'd be great to have a community health worker on the Oregon Health Policy Board.
Come on up. You got 3 minutes. You know the drill.
I signed the sheet. I don't know why it outside the door. Hi, I'm Bruce Thompson. I'm a family physician who's been retired for 4 years, and in that 4 years, I've become even a greater advocate for patients. As I should state that my son became a Medicaid patient when he suffered a severe accident when he was 16 years old. And so partly I'm here as a down payment on the gratitude I have for the state of Oregon and for the Medicaid program in general. I'm also here to represent Healthcare for All Oregon, and we have submitted a 5-page document. I'm not sure where it goes once we submit it, but I'm going to try to summarize at least some of the key points on that. I'll talk about 3 things in particular, and maybe 4, depending on how time goes. So the first topic is regarding spending targets. We tried to do an analysis where we came up with the same numbers as have been put forward publicly of the $2.2 million savings in generated savings over the last 5 years. And we were not able to come up with the same numbers. So we would appreciate it if we could publicly understand how that number was generated. If there's some specific methodology was used, we would appreciate being able to review that, because the public documents that we look at, we can't come up with those numbers. So I think that would help to validate the importance of building public confidence in what OHA does and CCOs do to make that kind of information public. So that's on spending targets in particular. But it does pertain to this whole issue of how do we build confidence in OHA and Oregon Health Policy Board. The second topic is on mitigating risk. And I guess I just have this wild and crazy idea that, if all 750,000 patients were in one risk pool, we would have a lot of administrative savings. If we didn't have to calculate risks and go through rate-setting processes ahead of time before contracting goes on. It obviously has led to some discord in the organization in the past. So it's the idea would be that a shared risk pool at the outset would have administrative savings, and that money could then go towards health-related services, such as funding of social determinants. My third topic is on value-based payments, and I know that this is a hot topic because the governor has directed OHA to address this and the Oregon Health Policy Board to direct this. However, there's not a good body of evidence-based data that legislators or OHA or CCO administrators can use to make reasonable determinations of what fraction of the expenditures are best suited to improve financial motivation. And in fact, extensive research in behavioral economics suggests that extrinsic motivation based on financial rewards and punishments are appropriate only in tasks that are routine and uninteresting. This is not medicine. Medicine is not routine, and it is not uninteresting. So medical professionals come with a high degree of intrinsic motivation, and the data would support that extrinsic motivation is actually counterproductive in these kinds of situations. So that's my comments on value-based payments. And finally, I would just like to commend OHA and Oregon Health Policy Board for the work that they put into building CCO 2.0. It just feels like a much better outcome will happen than we've had in the last 5 years. Thank you very much.
Thank you. And your comments, if you got them to staff, the written document,
Yes.
they'll be included with all the other comments that we've received from other institutions. So
Excellent.
we'll definitely get them.
Yeah,
If
thank
I could
you.
just, if I could just make one comment for the record, when we'll get you the chart that we're using to document the $2.2 billion, but the methodology is super, super simple. It's for the past 5 years, what did we actually spend versus what would we have spent had we been growing at 5.5% per year over that same period of time, which is the baseline used in that 5-year period of the waiver. So it's super easy math.
Well, I'll appreciate that, and we can respond to that offline.
Sure.
Thank you very much.
Thank you for the comment. Great.
Can I ask a question too? I think on the folks from the community healthcare worker group, we had requirements in our first waiver about how many community healthcare workers were being actively used that we needed to meet. I know that when we renegotiated the second waiver that I assume those continued, but I'm actually not sure. And it would be good to see where we're at, because the last report that we saw tracking that was we were very short. And I think it was a requirement that we had 15,000. And so I feel like to their comments, I think, and I also feel like to their comments and the Latino Health Center's comments, I feel like this is a key way where you can actually have people making those connections in a really real way that helps people move through a system, especially because one of those folks is a navigator who helps people move through the system. And so if you had way more culturally appropriate navigators, some of those challenges that the Latino Health Coalition could be addressed. So it'd be good to see where we're at on tracking that.
Yeah, we can track that down. I don't recall that specific piece from 2012, but I also don't recall us trying to take it out in 2017.
Yeah.
So if it's in there, it's probably still in there. We can certainly track that down. And we're going to have some discussion about community health workers, I think, later today.
Yep.
So that'll be a good topic then, too.
Great. Thank you. Director Allen, you are up next.
Thank
Ready?
you. I am. And I guess there's sort of lots to report and not a lot to report. From an organizational standpoint, the organizational structure that you all approved at the June meeting went into effect on July 1st. We're now out on the street recruiting a Medicaid director and a behavioral health director. The Medicaid director position closes the 15th, I believe, of this month, and the behavioral health director closes at the end of the month. And we're out kind of, beating the brush, looking for suitable candidates. Getting a little bit of feedback that the election is a bit of a barrier for us, not our election so much as other elections around the country, and sort of expectations of the fact that there may be a number of new Democratic administrations, and so some sense that people are maybe tempted to keep their powder dry rather than applying here. So we'll see if that materializes or not when the 15th rolls around.
We're still the best. We're still the best state to work in.
Well, I agree. Anyway, that's kind of the internal status. Externally, we'll talk more throughout the morning, but with a huge amount of help from a huge number of OHA staff all across the organization. We just finished the road show, 2,000 miles, 10 cities, 2 tribes, about 500 Oregonians across those sessions. It was a really, really great experience. I've commented to a few people that you really actually need to put in that kind of windshield time on a trip to really appreciate the enormity and remoteness so much of the state. You get an hour this side of Ontario and on your way toward Burns and realize that other than literally the road you're on, there's not a sign of humanity anywhere else. And I think it's good to be reminded of that periodically. And then just it was a great round of interaction with people all around the state with a variety of perspectives, but really a lot of common themes. There wasn't sort of here's the flavor in this town versus the flavor in another town that was completely different. There were some facets that were a bit different, but really consistent themes across the state, and generally consistent with kind of the track that we're on, which I think is a good sign. So more on that as we finish out the morning. So all I've got, unless anyone's got questions about anything.
Does the Trump announcement that they're not going to fund the reinsurance program affect us?
Shouldn't affect the Medicaid side. It could have an effect on the rate setting process that they're in the middle of in the individual market. I also suspect that DCBS is looking at whether it's feasible to do a state risk adjustment program, which we do across CCOs on the Medicaid side as a way to backstop that. But I'm not in that loop at all.
Any other questions? Great, thank you. So we'll move on to diving into our CCO 2.0 conversation, and to lead us off, Jeremy, the Director of Health Policy and Analytics, is going to kind of give us some context setting to remind us kind of how we got here and where we're headed.
Yeah, so the next couple agenda items as we dive into 2.0 for the rest of the day, I was asked to give a little bit of background on 1.0 and some of the context around conversations and what was going on in 2010, 2011, 2012 when CCOs were first stood up, as a kind of a reminder of where we've been and some of the original vision and goals. Will be all stuff you've mostly heard before, but asked to give a little bit of context. And then we'll give a quick update on some of the more in the weeds procurement issues related to CCO 2.0, and then talk about the roadshow and community feedback that we've gotten as we transition into a meatier conversation towards the end of the meeting around some of the policy options. So I want to go to the next slide. And speaking of riffing, we basically just riffed the slide deck that we used on the roadshow. So you've probably seen some of this before, but I'll hit it pretty lightly. And we have about almost 3 decades of experience in Oregon in health reform. I mean, really starting in the late 80s around conversations of what were we going to do in the state to try to reduce costs and improve quality and expand coverage. And this is just a large reason why. I mean, this is all stuff you guys know, but as a country, we spend twice as much as the average of other wealthy nations in terms of health care. Next slide. And often don't get any better outcomes. Morbidity rates are often higher. Preventable disease rates are often higher. We don't have it in here, but another component of this has been just having people have access to coverage. Back when we started as a state conversations that eventually led to design of the Oregon Health Plan, the uninsured rate was about 18%. In 2013, at implementation of the ACA, it was about 17%, and so that was a huge just component of people not having coverage, it being too expensive, and not getting the quality and outcomes that folks wanted. I think in 2010, 2011, I think there was sort of a perfect storm of 3 things that came together. One was we had really a number of building blocks that we were building upon over those last couple of decades around what really needed to happen in a reformed delivery system. Before OHA, there was the Oregon Health Fund Board that operated for 2 years, and they put a lot of those building blocks together in terms of things like needing to focus more on prevention and a more coordinated primary care system and pay for outcomes, things like that. We had a managed care system in the state for almost 2 decades, and that had served a lot of, served us well in a lot of ways, but had also become really fragmented. We had something like 45 different contracts with different physical, behavioral, oral health providers, and those contracts weren't awarded through a competitive procurement process. It was really through an application process, and they were one-year contracts that had, for the most part, been rolled over from 1 year to the next. And so accountability and trying to sort of change the delivery system on the ground through contracts that were being renewed year over year was, I think, a challenge for the agency. So they had a lot of the building blocks. We were trying to build, as an example, a patient-centered primary care home program, but there was challenges in terms of how do you actually implement it and what are the tools to implement it. But we had a lot of those building blocks, even things like a focus towards global budgets. I think there was a growing recognition that we needed to move towards something more like a global budgets. I think the second piece of that kind of perfect storm was the legislature had actually created OHA in 2009 and given it a really aggressive transformation and health reform mission, and tasked it with better leveraging its purchasing power to implement those different building blocks for a transformed healthcare system. And then third was a budget challenge, and I guess the old saying is never let a budget challenge go to waste. And I think that was the third component of we had two decades of ups and downs of trying to add, reduce that uninsured rate and expand coverage, but then tough budget challenge times coming and falling back on the three tools that the state had traditionally used in tough budget times, which were cutting in provider rates, cutting enrollment, or cutting benefits, and those had sort of run their course. And I think there was an acknowledgement that any of those doesn't really solve the problem. It just creates a short-term savings and a long-term cost usually. So, when we go to the next slide, in 2011, there was work really started with a 45-member work group that met, known as the Wednesday night group of a mix of stakeholders and legislators, and really dove into if we were to redesign the system and try to achieve savings through a better healthcare system as opposed to just cutting benefit or eligibility or enrollment or benefits, what would those look like? And these were sort of summarized, I think, the goals that came out of that group and ultimately reflected in legislation and ultimately in the current CCO contracts, which were really needed to focus on. And I should say a lot of these goals, frankly, were part of the state's reform initiatives or vision for the predating CCOs, but really, I think for the first time got captured in a model of care that really put it all together. One was improving in health and not just focusing on health care, but focusing on people actually being healthy and having improved population health. Reducing waste and costs, acknowledgement that some estimates are as much as a third of every dollar that gets spent in healthcare doesn't actually improve outcomes or improve healthcare quality. Third, local accountability, a concept that really need to have buy-in from the entire healthcare system with one global budget and local decision-making around how to best leverage that global budget to stay within a sustainable rate of growth, but also make sure that you're achieving local community needs. Four, aligning financial incentives and getting rid of the kind of perverse incentive to just provide more and more and more, even if it's not providing any benefit to patients. Related to that, paying for better quality and better health, and actually moving away from a quality-based system to one that's paying for quantity of, or excuse me, one that's moving away from a quantity system and one that's paying for quality of care. 6, coordinating care, recognizing that patients often were literally having to carry messages from one provider to the next and needing to relay things like, actually, I had an MRI last week, I'm not sure that I need another one this week, and having a system that actually coordinates and puts patients at the center. Maintaining a financially sustainable system and one that kind of forcing the system to live within a budget that the state could afford, and measuring performance. As I mentioned, we had a managed care system, but there wasn't a lot of data that we put out there publicly about how it was performing and what the quality of care was and things like that. So those were sort of I think the main components of what we were trying to achieve. Let me go to the next slide, and I think those are really reflected in what's in the CCO contracts now and a lot of what we've talked about. And I should preface this too, is part of the reason I think I was asked to give a little bit of background here is there was a really rich discussion at the June board meeting as we've been really focused on those 4 areas of the governor's letter. There's clearly overlap in those different policy options. Some of them are kind of redundant, some of them complement one another, and a lot of rich conversation about how do those actually align with the original vision of CCOs. And so we're spending the day today starting to try to make some of those linkages. After the CCOs were stood up, there was always a vision that this wasn't just about Medicaid in terms of the delivery system reforms that needed to happen. This is really about improving quality and outcomes for all patients in Oregon. And so, after CCO contracts were awarded, conversation switched to, okay, if we were trying to expand a coordinated care model into other marketplaces, what does that look like? And eventually moved to this flower chart and sort of six core components of what make up really the coordinated care model. And this is what we've been using since 2012. And so staff have been basically aligning the policy options with this to demonstrate that, one, they actually all further advance these 6 goals. They fit pretty neatly within there, and both are aimed at achieving the vision and direction that the governor set for those 4 areas, but really all about moving the needle in these 6 components. And I won't go through all 6 of these. The couple of things I'll say that are really specific to Medicaid that are sort of missing from this, or at least aren't clear if you just look at the flower chart, is really, I think, the local community budget or community-based nature of CCOs, and that core component that the local community really figure out how to stay within its global budget. Why don't we go to the next slide? You guys have heard lots about how we've done, but just to recap a couple of the key metrics since we've had folks in and out over the last several months. Clearly, we've seen some improvements in quality, and as well as reported health status by members and satisfaction with their CCOs. But as John McConnell mentioned back in January, there's still areas where there's more opportunity, particularly areas where there wasn't a linkage to the quality pool. We know better. Avoidable ED use is down, and that means folks are generally getting better care, getting care at the right place. And we've avoided $2.2 billion in costs, which we talked about a few minutes ago. The ACA largely covered the expansion piece of expanding coverage. I meant to mention this earlier, actually, that I think back in 2010, 2011, there was recognition that this was a challenge that the state was facing in terms of figuring out how do we bring that uninsured rate down to zero ultimately. But financing was always the biggest challenge, and with the ACA through the Medicaid expansion and the marketplace and subsidies, basically took care of a large part of that for the state, which I think really allowed us to focus on the delivery system reforms that needed to happen instead of just on how do we expand coverage. We know there's a number of challenges still ahead. We've talked about these a lot over the last several months. Disparities persist. We need to keep an eye on affordability and making sure that the system stays within a budget that the state can afford. Rising prescription drug spending is a challenge, and in a lot of ways usurping a lot of the savings in other places. We're still paying for quantity of care instead of quality, and not really related specifically to CCOs, but maybe more work that the board can take on over the next year or so of how do we find more opportunities to take the successes that we've seen in the CCOs and expand those to other markets. So why don't I pause there? I'm happy to ask questions. I'm not sure if that was the right level or Zeke, what you were looking for in terms of some context setting, but happy to take any questions before moving on to some of an update on some of the nuts and bolts of the procurement.
Any questions or additional context? Some of you lived
Lisa
through
was
all
here.
that too.
The benefits of doing the roadshow 10 times is that we can each deliver each other's slides.
Yeah. Okay.
I guess the one thing I would say is that as we later in the day move into the policy options that we're considering, it's a helpful frame for me to see kind of where are we building on work that we've been doing and where is it new. And I think part of the context setting that's really helpful is just this acknowledgement that we really are building on a system where the kind of most significant transformation kind of occurred in 2012, and there's an opportunity now to continue to build on that system in meaningful ways, but in ways that are enhancing both those initial goals and then what we've learned along the way. And I think that that's been validated quite a bit in what we've heard, both in the initial survey work as well as in the roadshow and other kind of feedback that we've gotten.
I guess, Chairman, this great summary of CCO 1.0, but what doesn't come out, and I think that we've learned through our discussions, is sort of where the gaps are in what needs to be added for CCO 2.0. And the discussions, I've heard through this forum is social determinants, moving upstream, moving population, better focus on equity, and a better analysis of financial incentives and outcomes across the CCOs.
Yeah, and I think we'll get much more into that in the next few minutes as we dive into some of the feedback that we've received from the public.
Okay, all right.
I think the other thing that I would just observe is you didn't talk so much about this, but it was a pretty political process in 2011, 2012, which both included kind of a public political process and a fairly private political process, which kind of was what it was at the time. But I just want to say that I think that some of the way that process occurred was predicated on the idea that you've got to get a few people in a room, because those are the power brokers, and have them decide what the system needs to look like and then build that system. And that at this time around, I think there's been a lot of intentionality and effort on behalf of the agency, so I appreciate that. But I think it also reflects what this board has been looking for as well, that acknowledges that you've got a lot of different folks that are engaged in this work, and that we need to hear from those different perspectives to really understand how to move the system. It doesn't mean that there aren't still different levels of power dynamics at play, but I just want to say that I believe that this process is really a good reflection of really trying to engage multiple parties in this work and get clarity, both in terms of input and opportunity, to be able to then move forward. So just appreciate that.
Can I just say, I don't agree with that analysis of the previous way that CCOs came about at all. I think when the first concept came up, we had 182 public meetings around the state that were 2 to 3 hours long for each of those public meetings, where we did a whole process where, there was roundtable discussions, a list of questions. Those questions then got put into a report that came out that was really helpful about what the overall healthcare system in Oregon should look like, that then went forward into a legislative process. Like, I would say, I just feel like saying that it was a small group of people, when I think a lot of community groups, a lot of people who are in this room and not in this room spent a lot of time trying to influence the process the best way they can. So, and I think then we then held a round of public hearings and meetings where organizations and people then turned out hundreds of other people to weigh in. Did it come out perfectly as everybody expected? No. But I don't think I don't want anybody to walk away from this thinking that a handful of people came up with the idea of CCOs, when it was a huge community effort and level of engagement. Now, the Wednesday night group may have come together, which was a smaller group of people. That group was public, to talk about the piece of legislation that came forward. And then there was a smaller group to talk about the funding mechanisms and the budget. All of those then went to the legislature and went through a second round of public hearings. Those public hearings were held at night. Lots of people then came and testified at those public hearings. We turned people out to testify at those public hearings who are community groups and activists. And then we went into a waiver discussion with the federal government. I just feel like saying a small group of people, there was no small group at any point. And I think some people have that perspective and may want to bring that forward, but I think every single community organization who came out of that, who spent a lot of time and energy investing in that, who did all of that work, should be recognized, because right now they're having to do it yet once again 5 years later to get the next set of better outcomes. And after that, they'll have to do it again 5 years later to get the next set of better outcomes. So I just want us just because an organizing journey isn't done doesn't mean it didn't exist earlier.
Yeah, thank you for that, Lisa. You're right. I agree that there is also a pretty significant public process there. I think there were multiple processes going on, but thank you for that context.
All right, so I wanted to give you a quick, it's kind of jumping around a little bit, but I'll give you a quick update on some of the more nuts and bolts procurement design issues, some of which we've talked about before in a couple of updates, and then we're going to dive into 2.0 and put in process and themes. So there's basically 5 things that I want to cover real quick in terms of design features of the procurement. We've done now a notice of contracting opportunity where a couple of these have been discussed, and they'll continue to be updated on ORPN and on our website as we go through them. The first 3, as we've talked about, a request for application process instead of a request for proposal process. Expecting an RFA would be released in January. Really the big difference is in an RFA process, you're not shooting for a magic number. You're really more focused on setting a bar and making sure that bar is at the right place, and anybody who can get over it is awarded a contract. The second piece, which we've also talked about in terms of who could apply, and we've announced that would be folks with an Oregon footprint, so that would include current CCOs, but would also include organizations with a certificate of authority to conduct health insurance in Oregon. Oregon's federally recognized tribes and healthcare providers that have been taking financial risk. We've talked about the third just briefly, but want to make sure we have a little bit more time for this one. If you have questions, we're considering right now a regional approach in terms of applications. Current CCOs would be allowed to either apply for their current service area, or if they wanted to change service areas, that we would have some predefined regions. And these regions really would not necessarily reflect where ultimately the delivery service lines for sure end up, but would allow us an opportunity to evaluate applications based on unique features of that particular region. The 2 others that aren't on this slide that we'll be posting online very shortly here is letters of intent. We had a letters of intent process back in 2012, and are considering considering a similar process where after the RFA is posted, before the applications are due, that we would seek letters of intent that would have some just basic information around the organization that's applying and the service area that they're applying for, so that we've got some basic information about coverage before applications come in, and those would be made public so other applicants could see who potentially is in the playing field. And then the final one is around how do we handle rates in the middle of a procurement. There's a variety of ways that you can do that, and where we're leaning towards right now is establishing what are called procurement rates, which would be the agency basically saying these are the rates by these regions, and you can apply if you accept those rates, and then doing an after procurement adjustment as needed to account for things like change in benefits through the legislative process or things like that. So those are kind of our five issues right now, all still sort of tentative, but wanted to get those all out there.
So
Hey, this is John. Can I ask a question?
Yeah.
Did you hear me? Does the Oregon footprint requirement extend for the entire 5 years of the contract? Can an organization that doesn't have an Oregon footprint acquire a successful CCO 2.0 contractor, 1 month after, and that organization not have an Oregon footprint? You follow me?
Yeah, I think you're asking if once we award a contract, are we going to then require that contract can't be assigned, or that there can't be a buyout in some way? We've really just been thinking about this as a entrance requirement in terms of who can actually submit an application that they need to demonstrate that they have an Oregon footprint.
Yeah, I mean, my concern is, I keep looking back at the definition of a CCO, and the words that resonate to me are local, community, those sorts of issues. I think regional is probably okay, but, I think that's an issue. that there needs to be more discussion about what does that mean, and to what degree are we and the CCOs who are working with us really going to live by? So that's my comment.
And I'll just say the goal behind the broadening it beyond just current CCOs was to allow some flexibility for the system to evolve as needed, and for communities to make sure they have the right partnership that's needed for meeting there's needs. There's still a number of other sort of local and community-based requirements that are currently in statute that would still apply.
So one of the things that I would encourage for us to make sure that we look at as we talk about service areas is we have a lot of data now about where patients receive services, and that we make sure we look at that data to understand where people go, and that we're honoring that, so that when we award contracts, we're not breaking up those relationships that might exist for the convenience of a CCO.
Yep.
So I would like to see that somewhere that indicates that that's part of the process whenever entities apply or when we set service areas.
Yep, that's been on our mind as well.
So, and can I make one other comment? The folks who did CCO 1.0, I don't think they knew they were doing CCO 1.0, that they were sure there was going to be a CCO 2.0. And so kudos to them for jumping off of the cliff, so to speak. And I know locally, a lot of those conversations, they were building the plane as it was flying.
So in terms of service area, does that mean a CCO could only apply for its current service area and not expand, or so there is option?
Yeah, they would be basically have the option of applying for their current service area, or if they wanted to change, they could apply for one or more of the regions.
Okay.
What we want to avoid, now that to the point about data, what we want to avoid, given the amount of data that's out there, is sort of a create your own regional definition that in some way could conceivably be designed to pick a healthier population or something, something along those lines. So so it'll be either what you have or a larger
or
preset,
something larger,
something that we pick.
Okay. Right.
So, and the goal there was to not force the disruption if current CCO wants to apply and is happy with its current service area, but to sort of organize the chaos if we have a whole bunch of new applications, or if all the CCOs want to change service.
But it's not restrictive.
Correct.
Okay.
Have you in the process decided whether or not you're going to be potentially awarding multiple CCOs within a single region?
So by nature of the request for application process, we're not limiting the numbers.
Do we have data to show whether in the areas that have multiple that they do a better job for the patients or not? Have we looked at that?
We have so few areas where there are multiple CCOs.
Yeah, there's only really two parts of the state. There was two parts of the state, now only just one, which is Southern Oregon.
Yes, so Southern Oregon, I think, has 2 areas that have crossover.
Yeah. I don't know if we've done a direct comparison. I mean, we clearly put out quality metrics for all of the CCOs, and they all generally have been improving quality year over year. So I don't know if we've seen a trend one way or the other.
What I hear from clinical providers in those areas is they literally have to create 2 or 3 processes in order to accommodate 2 or 3 CCOs. So I'm not sure that increases their efficiency and possibly their effectiveness.
Yeah.
And if I could just expand a little bit on Jeremy's earlier answer, it's absolutely right. The RFA process doesn't say that we've picked a number of contracts, but those requirements would expect to include things like financial viability, network adequacy, coordination across the region, interaction or integration of the community health plan and assessment and all those kinds of things. And some of that would kind of tend toward asking tough questions of if we pop up with an area that's got 5 entrants, it would be, I would imagine, hard for 5 entrants in a small geography to be able to satisfy those kind of requirements.
And there's still some details we're working through. We wanted to get this out there and let folks know we're thinking about it. But But Pat's absolutely right in terms of things like financial viability, and then the other component, I think, an area we'd be looking to the board for some guidance too over the next couple of months is in any part of the state where we potentially have more than one CCO, what are the types of things we should be doing to try to align efforts or make life easier for providers or have a larger impact in terms of CCOs working together to try to move the needle on some of the goals of CCO 2.0.
Could I ask a question?
Yep.
Along the lines of Carla's statement, one aspect we should be able to estimate is, do multiple participants in a region increase or decrease the administrative costs for everybody? I have a concern that at some point, multiple competitors are going to increase administrative costs significantly, and I'm just getting more and more focused on administrative costs. So I would just want to put that into the mix.
Jeremy, it's helpful to see this as we're moving, as you guys are thinking about the procurement process, and I appreciate the call out of some of the questions that may that people are thinking about. As we move forward, it'd be great to get a kind of a bigger picture of what are the kind of assumptions and values, and it may even be tied back to some of the previous slides about what is it that we want, what are we trying to accomplish through this procurement process, and how is that procurement process designed in a way to reflect what we want those outcomes to be. And so it's kind of like, what's the box that we're creating and why are we creating that box in order to get there? And I think some of it comes through in what you were talking about, some of the flexibility. But as you've said before, this is likely the largest procurement process the state has engaged in to date. And so there's a good opportunity, I think, to create some transparency about what you're building into this set of processes and how that reflects what we're trying to accomplish. So I appreciate you bringing it, and I think as we move forward, that we'll want to keep doing that.
It's just worth keeping in mind that some of those values are delivered in the procurement itself, and others, I suspect, more actually are delivered in the terms of the contracts that result from the procurement. So thinking about both elements of that as the tools that we're using to deliver those values.
Yeah, no, I think that's really helpful, and I think that I think there's an opportunity in that to be explicit about what are some of those elements that play out in the contracting process, both in terms of the initial negotiation, but then also in the management of that contract over the period of time. So that feels like that's a really, once we get clearer about what is 2.0 here, how that's then manifesting in each of those different elements of the relationship between CCOs and the health authority will be really helpful.
All right.
Hello, everyone. My name is Steph Jerem. I'm a policy analyst at OHA, and I will be talking with all of you today about the CCO 2.0 input process and the themes we've heard so far. I'm going to do a summary overall of what we've heard over the past 7 months, and then everyone who participated in the roadshow, I think Jeremy's going to lead you through a little bit of a discussion around what you've heard there. So just to give an overview about our public input process, I think we've been trying to be very intentional about being clear about how the input actually gets used on top of actually taking in the public input and feedback. We've been using public input and feedback throughout this process to help us understand what's working in CCOs, what we really need to keep, what isn't working and might need improvement, so understanding a little bit more about on the ground what that looks like, new ideas that should be considered that we haven't thought about, and how issues might be prioritized based upon community interests and need. That public input, as Pat was just saying, can actually be reflected in the contract language. It might be in procurement. It could just impact our business practices at OHA, help us understand a little bit more about reporting, transparency, things like that. Or it might help set the stage for our long-term vision of CCOs, years in the future. So just at a high level, here is the map of the public forums in the roadshow. So this goes back to April. There were 4 public forums conducted in April. Those are the ones in purple, if you can see that. And then the 10 roadshow events that were held throughout the state that are in blue. This just gives a summary of what Pat nicely summarized already about the type of distance and some of the stats around the roadshow. So 10 communities, about 2,000 miles of driving. We had over 500 participants in these 10 events. We've had 21 news stories that we'd love to share with all of you, and over 36,000 people who have been engaged in some way through social media. Overall, so this stretches back to March.
I'm sorry, Steph, can I interrupt just real quick? I want to comment on the news stories for just a second, because those news stories got to reach down to, the local weeklies and and really small publications that we often don't get a lot of reach into. And so I think one of the benefits of going out in that fashion was really getting, I think, a higher degree of public awareness in communities that wouldn't otherwise maybe have gotten touched that way. Thanks.
Yeah.
If possible, too, I just think I've seen it through I've seen a number of those stories, but if other board members haven't, it's really interesting to see how those local communities are interpreting those roadshows, and both where there's real consistency, and not just because there was a press release, but where you can really see that the reporters have engaged, and where there's some nuanced distinction.
Sure. Yeah, we have a list that we can send out to you with all the links. And then this is kind of a summary of our public input opportunities to date. So this stretches back to March. We had over 25 health committee meetings, so some of the health policy board meetings, but then other committees of OHA that received presentations, weighed in on policy options. We had all of your meetings and public testimony. There were presentations at over 20 conferences and meetings. We had 2 formal tribal consultations so far. We're hoping for a full tribal consultation later this month. We've had 13 CCO Community Advisory Council meetings that innovator agents went out to and conducted some in-depth feedback and survey responses with them. We had the 4 public forums and the 10 roadshow events. So those were all in-person events. And then online, we currently have a survey open, which I'm going to talk about in just a second. That mirrors the roadshow experience. So if you weren't able to attend the roadshow, we basically walk through the same information on the survey, and then people can provide their input that way. We also had the March and April online survey, which had about 1,500 respondents to that. I'm going to show the results from that too. We've had emails to CCO 2.0. We've been gathering feedback that way. People have been sending emails that way. And then we've had at least 25 letters and formal comments from different organizations, CCOs, healthcare providers, community-based organizations throughout the state. Those are all posted online at our website. They're all often directed to the Health Policy Board, so hopefully you've gotten a chance to read through those. And our policy team has also been taking all those into account. What we heard overall so far, this is a refresher. This came from the first survey, so again, about 1,600 people. Behavioral health was for sure the most important thing that people wanted to see addressed in CCO 2.0. We also saw social determinants of health, care coordination for patients, health disparities, health equity right at the top. So this is all really consistent with the direction that the governor offered and the work that we've been doing so far. The surveys, we had over 700 open-ended, very lengthy comments from that survey that we've read through extensively. Our policy teams have looked at as well. This just gives you a summary of where the comments came in. So interestingly, we had cost and funding right at the top of what people had a lot to say about and how things should be funded or lack of funding, challenges with funding. Behavioral health, social determinants of health, and governance were the other ones that were right at the top. And I think we've shared that with you, but all those comments are also publicly posted online at our website. If anyone wants to read through 700 comments, they are all there. And then this is for the survey that's out right now, and this also, again, mirrors the roadshow experience. It's open until August 1st, so anyone who wants to still take it, it's available at our website. You can go to health.oregon.gov. The data that was pulled is just right now a preview. We're not trying to say this is the final results. It's available in English and Spanish online. We have about 200 that were pulled at this point. We have 300 total right now. 92% of the survey completers are at least somewhat familiar with CCOs. and we had 64 OHP members or family members. We asked some questions at the front about satisfaction of OHP, just to see what we could generate here. We see that about 60% are very satisfied or satisfied with the Oregon Health Plan care and services. And then 58% are satisfied with their CCO specifically. Here's a list of the stakeholders. We see at the top that community-based organizations are the most common respondents to this, and the local public health and the general public is up there. And about 20% also identified as an OHP member and or family member of an OHP member. Just a layout of all the different CCO regions. We are happy to say that we've at least gotten a response from every CCO region or someone connected with every CCO region. So you start to see some there. And then similar to the roadshow, we asked survey respondents to focus on 5 policy options and 5 policy areas specifically. So community involvement, value-based payment, sustainable growth, social determinants of health, and behavioral health. In general, they were asked about some specific policies and said, what kind of an impact do you think these policies would have on CCOs and on the Oregon Health Plan in general? Positive, negative. You can see here where we're currently at. This is not exhaustive, so the survey was written in a way to give a really high level of what we're thinking about. And I think with that, unless you have any questions on the public input process so far or the surveys, I'm going to turn it back over to Jeremy to talk more about what we heard from the roadshow.
Stephanie, do we also have a member survey specifically out in the field, or that's going out in the field?
We have had a member survey open. It's online, and we also have had, that's what the community advisory councils have been working on generating. We've gotten some mailed back to us as well. There's also, in an attempt to reduce the confusion over surveys and to work with some best practices, we've actually changed the format a little bit, but that engagement is going to continue throughout August, and there's a slide on that in a little bit.
Let me go to the next slide. So these are sort of the 5 big ideas that we've framed the roadshow interactions and input around, and there's 5 instead of 4 because the first 4 are the 4 that were outlined in the governor's letter. But there were several kind of cross-cutting strategies throughout that really hit more at transparency and accountability specifically, and knowing that was also a priority of the governor and of the policy board, we pulled that out. So it looks like a 5th, but really it was kind of a repackaging of some of the policy options underneath it. And as it's said on here, we've heard a lot of feedback around making sure we don't forget about oral health as well. I think I'm going to do is just, we really wanted to have Pat and I have an opportunity to provide at least our perspective on some of the themes that we heard. There'll be a longer report coming to you before the August meeting. That's a more formal and more thorough update on all the written feedback that we've gotten from folks that attended. But I'll go cover a couple of themes. Pat, jump in with your thoughts. And for each of the 5 areas, and then also want to open it up to the board for discussion. I know that several of you attended 1 or more of the meetings, and so would love to. This is our perspective on some of the themes we heard, but would love to get your perspective on some of the themes you heard in the conversations as well. So on behavioral health, what we sort of said the big idea here, the big vision, we're really making sure that folks get the right care at the right time, meaning that they, CCOs, make sure the members have immediate access to the mental health and addiction services or collectively behavioral services that they need without patients having to navigate the system on their own. Just a couple of key themes. I mean, as Steph mentioned earlier in the survey, we also heard pretty resounding feedback that behavioral health is a big priority area that there needs to be more focus on, and that while there's been pockets of integration, we have not fully cracked that nut, and there's a lot of work to do to improve behavioral health integration outcomes for patients. Needing to break down silos and make sure that physical health and behavioral health providers can work together, including addressing some challenges that frankly are probably on the state, like billing and licensing issues. There's definitely, I think, we'll get to some of this more in value-based payment, definitely a theme around having providers have more flexibility in terms of how they get paid and how they can use the payment that they have to meet the patient's needs, regardless of what those are and whether there's a particular billing code for it. And a lot of feedback around making sure we've got diverse, making sure that providers represent the diverse communities that they serve, but acknowledging that we've got provider shortages around the state that we aren't going to be able to fix tomorrow.
The only thing I would add is for sure providers that are as diverse as the community, but beyond that, just providers. Sheer lack of access to providers, and not because someone's gatekeeping that access, but because they just don't exist. And the struggle with with how growing your own is one thing if you're talking about a community health worker. It's another thing if you're talking about a psychiatrist. And the struggles that were pretty universal all across the state around that workforce supply issue.
And I'll just add one more thing. This was the first question that we kicked out to groups, and they had group discussions. And I'll say a lot of the feedback that we got immediately was, well, actually, if you want to address behavioral health, you also need to focus on social determinants of health and health equity. And we're like, well, that's coming next. And then around paying differently, which is also another topic area. So it just goes to show how these complement each other or interact.
Yeah, so social determinants was the second topic that we pitched to groups. Have we talked about what the format of these was for people who weren't?
No, I guess we haven't.
Who weren't there. So we, the way these worked is we had a 2-hour block of time, and we spent between Jeremy and I the first half hour or so going through many of the slides that Jeremy started with today, just for kind of orientation and level setting about some facts about the system. And then we went into these 5 topic areas and gave on the screen a high-level idea of what might that mean in terms of options. And then people had available to them a more detailed spreadsheet that went into a level deeper of detail. And we gave them 12, 13, 14, 15 minutes to have a table conversation or a small group, depending on the seating, to kind of kick that around. And then we asked for a little bit of report out. We generally had staff at each of those groups taking notes, which is where a lot of this where this comes from. But that was kind of the general nature. So the second conversation was around social determinants. Again, we got a fairly strong feedback that resonated with people. Housing came up just over and over and over again as a critical issue. I was impressed with kind of the refined nature of that input, because it was housing is a problem top to bottom, but not, and we expect the CCOs to build a bunch of housing. It really was a fairly refined reflection that there's a role for CCOs to play in helping address that issue, but it's not the primary role, and that's not that there may be some things from a financial standpoint that can be helpful, but there was not a lot of feedback that said CCOs should go out and build affordable housing or those kinds of things. There was a lot of feedback as well around traditional health workers, especially community health workers, navigators, those kinds of things, and the ability of on the one hand, the ability of them to be a vital and cost-effective way to improve access to the system. But second, we heard in different places a little bit of different flavors of what are some of the barriers to being able to effectively access them. Some that we've talked about here before around what are the expectations that we have of CCOs with respect to traditional health workers. Others were some things that I hadn't heard before around licensing and qualification and those kinds of things. So some topics to work on there. And then lots of feedback on the third bullet around care and coordination and contact, very consistent with the public comment that we heard earlier today around in the right language and culturally relevant and all those kinds of things.
The only thing I'd add is I think beyond housing, the next area of focus that I heard a pretty common theme around is around kids, and particularly kids and families with ACEs, and focusing there and recognizing that early interventions are really important, but they also take time to see the payoff. And I think it's funny, the social determinants of health has evolved. I feel like in 2011, 2012, we were talking about air conditioners and prevention, and that has sort of evolved into social determinants of health and everything CCO should do around social determinants of health. And I think that has evolved now to a lot more community partners saying, look, we're actually all doing pieces of this, and how do we work together to have a collective impact and align resources and figure out who can bring what to the table.
In Ontario, childcare came up as a social determinant topic that hasn't been on our radar before. And I thought that was of note, and that was also probably the session that was the most heavily weighted toward members and general public of the various sessions. So I thought that was worth noting too.
I agree. The one I went to, I thought was very interesting was that there really seemed to be an understanding that the CCOs need to be part of the social determinants of health conversation, but not necessarily in charge of it. Does that make sense? Mm-hmm. That if you truly want to make a difference in social determinants of health, the whole community has to be involved with it, that there has to be a commitment across the whole spectrum. It can't be just, say, to the CCOs, you are responsible for this.
Just to tie the two pieces around housing or social determinants and then kids together, at the forum that I went to at our table conversation, one of the people who was at the table was just commenting on how, kind of from her perspective, you know, we as a state recognize that we need to have coverage for our entire population a few years back, and that the starting point for that, because it was both doable and because you could really count it and because it made sense, was with kids, which we did. And she was just proposing, you know, part of the issue with this notion of social determinants is that you hear a lot from people about how it's too big, we don't have the right resources, we don't know how to tackle it, and you know, there may be some value in targeting or focusing that around a particular population, like kids, and say, okay, why don't we focus on thinking about how we're really addressing the housing stability issues for 0 to 5-year-olds and their families, and the role that CCOs and that the healthcare system can play in that. And I hadn't thought about that idea of kind of splicing it that way and thinking about a particular population as a starting point to really get some traction and to be able to show what we can do as a state and not have it be this wide open box that people just aren't really willing or able to kind of make any movement on.
Let me just reinforce that. And since our last meeting, I've spent a fair amount of time talking with some of the pediatricians at OHSU who remind me a very important point that I learned in medical school, that kids are not just small adults and have very different needs. And we haven't really looked at this through a pediatric lens in terms of how there's different social determinants of health, different approaches, and different impact on bending the cost curve for kids. I would encourage OHA, you know, as we go through these contracts or develop these contracts, to make sure we're looking at through a pediatric lens, especially since half the kids in Oregon are affected by the CCOs.
Yeah, the other thing worth pointing out is that because they're not small adults, kids don't live alone. They have parents or caregivers, and so a lot of our strategic work around kids right now is focusing on a 2-generation approach, trying to recognize that if you've got issues with the kid, you've probably got issues with the parent, and you have to, or other caregiver, and you have to. You can't just focus on the one without making progress on the other, or you don't get very far.
And I think you're poised especially well for that with your chief medical officer, who's an expert and very well-respected pediatrician.
I got to learn it somewhere, right?
All right, should we move on to the next one? Reducing healthcare costs. We proposed, obviously, we have to stay within our 3.4% that's part of our waiver in our budget, but moving more towards keeping OHP costs in line with some other indicator like cost of living or budget growth or something along those lines. Some of the feedback we got, clearly folks are concerned about costs, but they're also worried about those savings coming from things like reduced reimbursement rates or things that would create access issues. A lot of, we specifically threw out prescription drugs as an area we were concerned with, but we got a lot of feedback about that, and I would say kind of surprised about the number of times that a statewide or aligned preferred drug list or other ways that the state can align its purchasing power came up. I was mostly just surprised because that's sort of a wonky thing, and I was surprised how many folks were even aware of what a preferred drug list was, but that came up multiple times as a way to try to address drug costs is trying to find ways to better leverage the state's purchasing power. Recognizing we've got a lot of constraints, and there'll be a longer conversation about that next month. Pat, anything to add on cost?
Pay for better health. This is the whole value-based payments discussion, and we've sort of summarized it here in a single bullet, which was this sort of mix of, interesting, but lots of potential downside and challenges and engineering kinds of issues to avoid unintended consequences. Up to and including just outright skepticism that we should be doing anything at all in value-based payments, and a kind of a full range. But at each, and this, by the way, this is in a point where we tended, the discussions on social determinants and on behavioral health tended to run a little bit long. So at this point, we were kind of ratcheting time down a little bit to try to land within a reasonable time, and so these discussions were a little bit shorter, but it was that balancing notion was the main message that came out.
Yeah, I really heard a resounding theme of when you asked the other questions like behavioral health or social determinants, feedback you got was providers saying we want more flexibility and not be stuck to billing codes and encounters. But then when you asked them, well, how do you feel about moving to value-based payments? A lot of questions of, well, what infrastructure is that going to take, and what's the right providers, and do you start with primary care first? And we need to be careful and thoughtful. So,
and the nature of the provider was huge. The behavioral health providers, I think, I didn't hear this explicitly said, but effectively what they were saying is, for them, value-based payment means more flexibility to provide needed services not tied to billing codes and those kinds of issues. Physical health providers don't have that same perspective, and that's kind of an interesting dichotomy to sort our way through.
Can I just ask a question in terms of the feedback point? So especially if this change is not happening across markets, you're not talking about geographic markets, you're actually talking about payer markets, right? So,
right.
So in other words, providers don't want to have to, the more they have to, you can speak to this, but the more they have to work through different systems based on who's paying the bills, the more complicated and more administrative burden there is.
Yes, it requires us to use more brain cells, and we hate that.
This is one of those areas where it would be delightful if the federal government would stop messing around with the individual market, because we continue to be on the cusp of the market in Oregon being pretty stable until somebody at CMS wanders along with a hammer and whacks something and makes it less stable. With a stable market, one of the tools that the health insurance marketplace has is called active purchaser requirements, and so basically, aside from DCBS's regulatory authority, they get the ability in their contract to require things like standardizing on certain payment methodologies or other kinds of things that we've really not explored because the market has been so fragile. DCBS has, I think, appropriately been leery of wanting to go down that path and, ultimately push people out of the market because there's one more thing for them to worry about. But this is the kind of thing that we could deal with if we could get the market stable enough for that to be prudent.
All right, then finally, transparency, accountability, and this was at the end, and we had sometimes with some of them we had time to actually do a breakout, and sometimes we just facilitated an open conversation. Certainly did not hear anybody opposed to transparency and accountability or more transparency and accountability. Recognizing I think we've come a long ways in 7 years from where we were 7 years ago. In some ways we have too many reports. We need to figure out how we streamline them and make them easier to navigate and more accessible for folks. But had suggested be able to provide more tools that would show sort of efficiency or variation of costs across CCOs. Didn't get any pushback on that, and definitely a large theme around the importance of the community nature and local nature of CCOs, and several parts of the state folks said they were having trouble either figuring out how to interact with the Community Advisory Council or understand what was going on with the community governing board. Some of this will be addressed by implementation of Senate Bill or House Bill 4018 from the 2018 session, which requires public meetings with some exceptions that we'll have to define and things like that. But Certainly, a big theme in this was really around the importance of the community to be able to engage with the CCO and help and provide feedback as it's setting priorities and goals for its work. So I just wanted to make sure, I don't want to take over Chair Zeke's your meeting, but I want to make sure. I know John came to 5 meetings, and he actually gets the award for most number of meetings attended of a board member, but I don't know if there's other, we just wanted to make sure you all had a chance to provide any feedback on things you heard or things that struck you about the meetings.
Yeah, a couple comments. First of all, I think it makes a huge difference when the public sees the director of an agency in person. And Patrick, I think, thank you for doing that. I hope you didn't get a speeding ticket going from Astoria to Coos Bay.
No, I didn't. But I was in my own car, so that helps.
But I think that sends a tremendous message. Second, I would fourth an emphasis on children. That did come up over and over again in my small groups, that social determinants and should start with children. If you're, simplistically, if you're going to try to do something around housing, start with the children who don't have any housing, and try and stabilize for them. And same thing with so many of these things. Some of the meetings I'm at, they talked about schools and the degree to which a CCO and the delivery system could work with schools. Pediatricians, I think, and family physicians try to figure out schools and work with schools. And recall the presentation that we had in Astoria from the Astoria schools. I thought that was, a really compelling presentation, and I'm still left with the points that were made there about the children being picked up at the bus stop from Fort Stevens Park campground. That was compelling for me. I learned a lot, and I do think that the cost issue wasn't quite framed like we might have. I think if we had tried to frame the discussion on cost as including administrative costs, we would have heard a lot about the concerns that folks have around administrative costs. I think there are a lot of costs in the system that have very little to do with patients that can be changed. So I just thought it was a terrific series of meetings and appreciate being included. Thanks.
Great. Keep going, Chairman.
All right.
Okay, so this is our last slide on this, just to reference our ongoing OHP member engagement. So there's going to be a Spanish language forum held specifically with members. We're co-sponsoring outreach events with culturally specific organizations throughout the state, and we will be doing a phone survey to a representative sample of OHP members as well. And I think what's important here to continue to understand is that we're looking at this feedback as things that can continue to affect the system. Maybe some of this might not be in contract, but a lot of what we've been hearing from members are things about how OHA can do better, how CCOs can do better, that don't have to happen through contract, but we can continuously improve. So I think that's it.
I think the next piece is feasibility and impact, which will really lead into the longer conversation. So I don't know if you want to take a break now and then.
Yeah, no, I think what we'll do in a minute is take a break. When we come back, we'll hear about the feasibility and impact analysis that has occurred and how that informs the document that we've got in our packets. And then we'll have leads from different parts of the organization are going to come and, in effect, provide their input about that, both analysis and about those policy options that are there, and hopefully have some dialogue as board members about what we're seeing there and how we're thinking about that. So why don't we come back at 10:20, which is, according to my clock, in 11 minutes.
Hey, Z,
Yes, John?
I am probably going to be, not probably, I'm going to be on another call from about 10:30 to 11, so just letting you know that.
Thanks, and appreciate your some written feedback that you gave on some of what you saw there, so I'll try to make sure we incorporate that input in the discussion.
Okay, thanks.
If board members could make their way back to the table.
Hey, Z?
Oh, that's a cool slide, Steph.
Yeah.
What's that?
These are all of the community outreach partners from the roadshow. So in each community, we worked with community organizations to help us spread the word about the event coming. So we just wanted to thank them again.
Yeah, so I wanted to just say thanks to both the agency and to the community agencies for, to the community, the health authority and the community organizations for partnering around that. And I just appreciated that approach from the health authority and look forward to that both being an expanding list and continuing to be a part of the way that you guys do your engagement. So really thought that was both successful and it was great.
Great, thanks.
All right, so feasibility and impact analysis, starting on slide 32 in our packet.
Thank you. So I am going to be just walking through the process, and then we're going to be inviting up our subject matter experts to talk through the actual results. So just to orient you to the overall, what the next few months look like, what we're hoping for today in terms of the CCO 2.0 and the policy development work. This July meeting is really about bringing it all together. Jeremy talked already about the vision and the goal setting. We're trying to bring in our public input, our community input, trying to look at the policies, look at it as the bigger story of CCO 2.0. So thus far, we've really focused on these 4 topic areas, but really, what are you envisioning for CCO 2.0? Where do you see us in the next 5 years? Which of these policies will get us there? What are the big goals related to that? So today is really about framing that, starting to think about it in this larger context. Our August meeting will look at some more prioritization around these policies as we start to familiarize ourselves a little bit more. We'll have a report outline for you all to review and see if it's getting towards what you're looking for with recommendations. Your September meeting will look at reviewing that draft report. And then in October 2nd will be the approval of the final report. And at that point, it will switch over to our procurement team. We will be engaged in writing the actual procurement, and so public input and that type of engagement will be held off for the time period.
So Stephanie, just to be clear, so in terms of where we are today, in July, you're not really looking as a board to have kind of detailed individual policy discussion for the most part. This is both about like the full basket of options that we're considering, some clarity about how they fit within the different goals. You are looking for some input, some perspective from board members about how we're making sense of that so far. And there may be a couple of places where you call out some specific kind of policy considerations, but really in August and September is where we're going to do more of a detailed look at specific policy options. Is that a fair assessment of the distinction between today and the next set of meetings?
I think that's right. I think today you will see we've identified there's 7 policies or policy ideas that need further guidance and clarity that will help us to do some more of that prioritization come October, or come August rather. So it's a mix. I think we're still in the full basket picture, but we are trying to get towards narrowing that down or getting some prioritization or getting some sequencing, and so that can happen probably as we start to understand the bigger picture more.
Yeah, we thought about doing some speed dating with the policies where we would do 2 minutes on each one, but figured that probably wasn't the best approach.
I like that idea.
And then send them along.
So we've got a full basket, but 7 pieces of fruit that we've pulled out today. And then
Perfect.
a bigger discussion in August about more.
Thanks.
Can I ask a question about the process step?
Sure.
So I think some of these policies I have seen have clearly come up from the work groups that we have. And then has these policies gone back to the equity committee to talk through some of these on how they impact health equities? Or when is that in the process?
So Leanne will actually be stepping up in just a second to be walking through some of this work as well. So she will definitely have more that she can add to this, I'm sure. The Health Equity Committee was able to see this. They did offer us some substantial feedback around social determinants of health, health equity, and behavioral health that are written comments that are online that our policy teams have been addressing. So they've seen the whole package. But we would continue to engage them however they'd like to continue to work on this.
Okay, and so then those written, I guess I'm confused about the process. So when this comes back to us in the September, will be after some of those written comments have been incorporated into this?
The comments are it's
they
a constant
ongoing?
process of being
Ongoing.
incorporated, yeah.
Got it.
At this
Okay.
point.
It would, so
Thank
maybe,
you.
it'd be great from each of those different leads, but I think Leanne in particular, because of that interest, to be able to address the ways in which either committees and or internal work groups have informed the policies to date and what the additional informing will be as we move towards October. Does that sound right?
I think that's helpful. And then my other question is I'm blanking on it, what the group is called. It's the joint group with the Early Learning Council. And their policies are included in here
Metric
too.
Success Committee.
The metrics, like measuring success, I think Pat could speak to, we've been engaging the Early Learning Council as well on some of this. And
I'm not quite sure what joint.
It's the joint ELC.
So there
Yeah.
used to be a joint committee between the Health Policy
Policy
Board
Board
and
and
the
the Early
ELC.
ELC.
That committee hasn't met for a number of years.
Yeah.
There is a Measuring
Governor's-
Success Committee that is more in the early learning space, but that
Yes.
the OHA is contributing to. Is that fair to say?
That's fair to say. And then there's also Governor's Children's Cabinet,
Yeah.
which I think really has taken the place of
The ELC, the
of
joint ELC.
of the joint meetings, and that involves us, the Early Learning Council, and a variety of other agencies, including DHS, OYA, and others, working on what's the Governor's Children's Agenda, and what are those overlaps especially.
Great, and so those have come into this as well as part of the policy. The recommendations out of that group has come into this as well.
we haven't received any formal recommendations, but we've had many conversations with the Early Learning Council, with the Early Learning Hubs, and with the Early Learning Division about ways that they see their work being incorporated.
Okay.
So it's been included, but we can certainly pull that out for you.
So, and just to clarify, so when the staff really started this back in April, they had
Yeah.
an accumulation of ideas from the last 7 years, which was
Yes.
kind of the starting point, and then public engagement in April and May to collect more ideas. That all rounded out to be something like 90 or 100 different ideas. And now the next phase has been getting more input, doing more of
Yeah.
feasibility and impact, and frankly needing to get to the point where we're starting to narrow those to which ones actually move forward.
Yeah, so I want to make sure that when we're looking, so when I read through some of these things and looked at sort of the 6 areas that it meets of the coordinated care model and looking at the feasibility piece, I think, and the measurement system, I feel like I want to make sure that on some of these things, like paying for outcomes and value, for example, which is one of our goals, like if the Early Learning Council or the children, I don't know what it's called now. I'm just going to keep calling it the Early Learning Council. If the Early Learning Council weighed in to engage with the early value in some of those things, like it might be less, it might be a heavier lift, but it might provide a larger impact if we tweak some of the policies. I don't want to go into tweaking those policies right now, and I don't think that's what we're doing here. I just want to make sure that we're sort of rounding out with those groups around, okay, we've narrowed the list, we've got all this feedback. You get a second round of tweaks to these policies to make sure that we're impacting the system in the way that we want to impact them. And then they're going to come back to the policy board. Does that?
Yeah, I think we can certainly do that. I think
Okay.
if I'm hearing you correctly, it's more about like the implementation. So starting to understand if this is the policy, how could this be improved in your area specifically?
Well, I think an example would be,
Yeah.
we did a presentation for the Early Learning Council a month and a half ago on a variety of things, including CCO 2.0. And one of the things we talked about was the metric that we have for CCOs around early screening for developmental disabilities.
Yeah.
Well, the thing that you get back from the early learning hubs is, that's great. We screen them and now they need services, and we can't provide this. We don't have the resources to provide the services. So
That's right.
that's a linkage we need to know about and call out, and I think that's an example of the kind of thing that
Yeah,
we need to try
and
to
could you
flag.
just tweak the policy a little bit? So I feel like for another one of the examples is I don't know what page it's on, but one of them is the public health example where it says encourage CCOs to invest in public health. So if you ask the Early Learning Council what their primary investment in public health would be, it'd be nurse home visits, right? They would say. So should we tweak the policy to say encourage CCOs to invest in public health in these 4 key areas?
Right.
Or leave it broadly, or what? But
Yeah, or what things like home visiting, what things really are in the province of CCOs versus in the province of other investments we could make in the agency or whatever.
yeah, exactly.
And we're expecting a full, continued rounding out of input throughout July, August, and September. And I think if there's other lenses that the board really wants us to have, that's the type of feedback that's really helpful. So we're making sure that we're
Yeah.
using that lens as we're fine tuning things.
So I think for me, the lenses would be the health equity, which is outside of us, the Early Learning Council piece, the DHS lens, which I think is really critical because a lot of the overlap there. And then I think our internal committees like workforce, public health modernization, those other ones too, also get that second crack round.
I think the other thing that, if I'm correct, I'm hearing from you, Felisa, is as you all are describing the basket, and maybe a little bit in the context of both the how heavy is the lift and how large an impact, it would be nice to be able to understand in maybe some specific ways how that input has already been incorporated. So it's good to know that there's been a lot of engagement with all of those different bodies, but we can't see yet kind of how that engagement has led to kind of the policies that are currently at play.
Great. We can bring back for you next meeting the letters and the recommendations from each of the committees, and then how they've been addressed and considered. Okay, so just to continue to frame, as Jeremy mentioned, we've been trying to think about this, and this was a request that came out of the June meeting from all of you, is understanding the bigger picture and understanding the cross-linkages across these 4 topic areas, the bigger themes of what we're trying to do. And when we say CCO 2.0, what are we really expecting? So these are the 6 topics or the 6 elements from that coordinated care model flower. Our team did some work internally to update this a little bit, still with the idea of improving upon the foundation that we have, incorporating some of the keywords that the governor has identified and that we've also understood a little bit more. So like partnership with communities wasn't really in that first flower, but we think it's really fundamental. We've heard that from the public input process. So just some tweaks to that. Certainly just a draft and a proposal about how we can shape this a little bit differently to show that we're continuing to innovate and we're continuing to build upon that really great foundation. So you will see that the policies have been realigned underneath these 6 goals. This also allowed for some flexibility in adding other components that we've heard throughout the roadshow, and then we just know fundamentally we need to improve upon. So that includes some of the broader workforce goals, that includes HIT, and also includes oral health.
So Stephanie, think this is clear, but if we, as we use this framework, you all as staff don't feel that it in any way inhibits our ability to communicate back to the governor eventually around the 4 areas that she particularly specifically called out, correct?
Correct.
Yeah. We still have our teams working on these in our topic areas, and I think it's really just about understanding that there are greater connections, and we don't want to be existing in silos. We've been working as a team throughout this process, and so this is a little bit more accurate.
Yeah, I mean, the intent of the governor's direction was not to change the CCO model. It was to focus on some specific areas, and the work the staff have done have just aligned how those areas that the governor has asked us to focus on align with the original components of the CCO model, if that makes sense.
Thanks.
So our feasibility and impact analysis, this is something that we've been talking about, going a little bit more in depth. You've seen the policies, we've taken them out, we've talked about them, but now we really need to understand what's possible and what kind of an impact do each of these policies have. So the first step of this process internally was that our policy team went through and did a pretty thorough assessment on each of these pieces. So looking at whether or not the policy was fulfilling a state or federal requirement. Those, just so you know, in the document that lists them all, those are all starred. So that means that those fundamentally need to move forward. Assessment of whether or not there's a connection to other policies or topic areas, so which ones get strengthened, how do we tie these together? For example, like the traditional health worker pieces, if you can do a value-based payment and get traditional health workers supported, there's a synergy across some of these topic areas. Whether or not it's included in the current contract and just needs some more refinement around how we're holding CCOs accountable or how we're tracking that work. If legislation is needed that affects feasibility, any additional development needed. So if we've said, here's this great policy idea, but realistically, can we get that done by January, or will that have to change how we sequence things? The potential to reduce health disparities and looking at it from that perspective, whether the policy corrects a process or identifies an outcome. So we've talked a lot about process and outcomes and which ones the board wants to move forward on. We're going to have a further conversation about that. The potential impact overall on health system, OHA, and provider costs. We didn't attempt to identify or estimate any CCO costs at this point, just because of the range of CCOs. We heard a lot of these policy options. For one CCO might not be a big lift, but for another CCO might be a substantial lift. And I know that you all have a meeting that will be hopefully happening in July with CCO leadership. That will give us an opportunity to learn a little bit more about the CCO's perspective on how they see these policies and the lift and costs for them.
A quick question, does costs modify all 3 of those components or just provider?
All of them.
Okay.
Yeah. These are all estimates. Impact on the procurement process, so understanding if something has to happen by January, this coming January, to include in the procurement process, or if this is something that's later on in the contract. Risks, that includes things like public support, and then timelines overall. So that was step 1. And then we used all that information to roll that up, and this is a little bit of a rough roll-up, into feasibility. So in general, how heavy is the lift for this policy across the system? So we looked at this to say if it's one bubble, you're looking at a pretty easy implementation. It's straightforward. We know what we have to do. There's not a lot of additional work or resources needed. It might be part of the plan or an expectation that we're already moving on. 2 bubbles would be a moderate increase in staff time, resources, development, or funding. There might be some challenges or hiccups along the way. And then 3 would be a significant challenge to implement and will definitely require some new resources, whether that's funding or staff time, needs a lot of development, might have a new work group. You'll see the 3 bubbles as a feasibility. That doesn't mean we shouldn't do it. It just means that it's going to be a heavier lift. And so I think understanding that doesn't mean that it shouldn't happen. And then an overall estimation of impact. So in general, how much does this policy move the needle in achieving the goals of the model? So one bubble would be, it's playing a supporting role. It offers some clarity or direction, could have a small impact on our business practices, for example. Maybe it's just a change in reporting. 2 bubbles would be a medium impact. The policy will strengthen Oregon's direction, and we will see some type of effect throughout the state. And then 3 bubbles we've identified as really fundamental to moving the needle in this area of the model. It would have a significant impact, or it's really transformational.
I just add too. So we've met with CCOs twice in public meetings and had a conversation around the options and gotten feedback through discussion. We've asked them for this type of feedback, and we're meeting with them hopefully later this month. And what we'll do is actually send this. So to the extent we've gotten feedback to date, it's incorporated, but we're going to send this out to the CCOs and ask them specifically to provide their feedback from their perspective as well on feasibility and impact.
So that has happened, is happening, or
we've met with them twice and had discussions, and we've invited feedback. But we're gonna send this framework and see if that helps in terms of getting more feedback.
What kind of early feedback do you have? Do they say makes sense? This is crazy?
Well, we literally went policy by policy of almost the 92 over April and May. So I don't know if I could categorize all of the feedback that we've gotten in a couple sentences.
So Stephanie, you mentioned that you looked at if legislation would be needed or inclusion in current contract, but I don't see that reflected in here. I mean, was that part of your bubbles?
It's all rolled up, so I think that would be part of the feasibility. We could certainly call that out for you.
I think that's important because I do think it impacts whether it's doable or not doable and what the time frame is. And so I don't see anything specific in the description about the bubble saying this would require new legislation, which would, I mean, that makes it maybe I would think more difficult if you have to go through a legislative process versus changing the contract. So I think it's important to clarify which ones would actually require legislation versus just contract language.
And our policy leads can also point you to any of the ones that they've identified too. I'd like to orient you to the packet that you got that has the actual, I wouldn't call it a report, but the feasibility and impact analysis. So the first 2 pages run through what we just talked about. I will note that these are not in any kind of priority order at this point. And then the other thing to note is that Zeke asked us as a policy team to break these down a little bit for some clarity. So you'll see that the first ones that are listed are the ones that are new concepts. So really changing the way we do that we have CCOs practicing currently are maybe fundamentally different, or change funding, pretty significant changes. And then there's also a list of the policies within each area that build on and strengthen the current direction. So these are things that maybe, improve the role of the community advisory councils and offer more direction and clarity around that work, but certainly isn't changing the fundamental structure of a community advisory council. Within each section, we have a little header that explains, what we're trying to say is within this area, and then also the impact on the individual member and what they would likely see if these policies move forward and how they might see improvements in their care and experience. So, any questions on the process? Okay. I'm going to invite up, we have all 4 of our policy leads for each of the topic areas. They're going to come up and speak to you about some of these, the 7 fruit that we have selected out of the basket. These are all policies that need some further guidance, maybe some clarity, some actual direction, because at this point it really offers us a crossroads of what direction we're heading for the rest of the path.
Come on up. And Stephanie, as they're coming up, can I ask you one more question? Yeah. So as we move from into the next couple of meetings, we'll both do some prioritization, but also potentially some bundling as well, right? So there's some places either across goals and or within goals where policies might have an additive effect in relationship to each other. Are we we'll see a little bit of that?
I think we'd like to, yeah. That would be our goal.
Great. Okay. Welcome back, everybody. It is your show, so go ahead and dive in.
Why don't we introduce ourselves first? Okay,
Yeah.
so I'm Chris DeMars, Director of the Transformation Center.
Good morning. My name is Leanne Johnson. I'm the Director of the Equity and Inclusion Division for the Oregon Health Authority.
And I'm Mike Morris. I'm the Interim Behavioral Health Director.
And I'm Chelsea Guest. I'm the Manager of Actuarial Services Unit.
Great. So we have a series of slides where we'd like to get your input, as you've heard. So the first one that you have in front of you is we're looking for input on and direction on whether OHA should include policy options that set statewide priorities or kind of defer exclusively to local control and flexibility. And there are two specific policies that I want to mention here. The first one is related to social determinants of health spending, and just to kind of remind you of this policy option on the table. So for the social determinants of health spending requirement, our proposal is that there would be 2 years of infrastructure or seed money that would allow CCOs to kind of start spending in this area, and this is related to House Bill 4018, which is the longer term policy on the table for this. So our question is should OHA require one statewide priority of housing related services and supports in addition to the CCOs choosing one or two priorities there? The current thinking is their CCOs would choose 2 or 3. One of them, the proposal would be a statewide priority for housing, and the other 2 would be based on the CCO's local needs. I'll just lay out some of what we see the kind of pros and potential challenges. So having a statewide priority on the pro side could help gain momentum and leverage resources more efficiently. And it would also allow for OHA to kind of assess this process and look at over a 2-year period if there's a kind of consolidated statewide effort around funding. Does this have an impact, and is this a direction that we would maybe want to take in future years as well? On the potential con or challenge side, it could detract from CCO's abilities to identify local needs. To provide a little bit more context, housing, as you've heard already today, and I think at earlier meetings as well, housing has been consistently cited as a need through the CCO 2.0 process. It's come up in public meetings, community feedback, and surveys. For example, the CCO 2.0 survey that was fielded a number of months ago, 3/4 of the people that responded to that, or 738 people, identified housing as one of the top 3 priorities. Number 2 was trauma, and that was 419 people. So housing far away and away, kind of one of the top identified most frequently. In addition, the Medicaid Advisory Committee did a survey on social determinants of health. Audiences were CCOs and community advisory councils, which were about half of the 66 responses, and the rest were partners such as regional health equity coalitions and local health departments. And one of the questions was about what are your priority areas for future social determinants of health work. All of those audiences picked housing by over 20 percentage points. Trauma and food and diaper insecurity came after that. Finally, I'll just mention, and you heard about this earlier today with regard to the recent CCO 2.0 roadshow, we heard that partnership is key in the funding of social determinants of health. OHA has been working with Oregon Housing Community Services for several years on expanding supportive housing. OHCS is currently developing a statewide housing plan that's coming out this fall or winter that would allocate housing funding for housing infrastructure. OHCS and OHA have been talking about the concept of permanent supportive housing, which is one of the 9 draft priority areas for this housing plan. And basically what this would look like is the OHCS kind of funding that infrastructure piece, and CCOs having the opportunity to partner with local affordable housing developers to ensure services are accessible. So I think before I move on to the next policy option, I'll just stop there and get your feedback. Looks like Jeremy might have something to say.
Well, I just will clarify, I think there's kind of 2 questions here. Mm-hmm. One is, do we want to set a statewide priority? And 2, is housing the right priority if we do? And I think that's a little bit of tension here in terms of, how prescriptive do we want to be as a state in terms of telling CCOs where they need to focus on social determinants versus totally leaving it to them and their community needs assessment and health improvement plan.
Well, I this is a social determinant of health, but I guess the way I perceive this is there's lots of evidence to indicate why you need to address this. So I don't think this is just about priorities and what the feedback has been, but there's actually evidence that shows that when you provide a person housing, that they are healthier. And I think it's really important that as a state, we continue to look at those kinds of data to show that the reason why this should be a priority is not because it's at the top of the list, but because of the studies that have been done. I guess the other question I have, though, is it seems like to me this should tie into our quality metrics. So why are we choosing to pull this out this way versus tying it into the quality metrics? And I'm sorry, John's not on the phone because he could probably discuss this. So I think housing is so important that it needs to be, I guess the conversation I feel like needs to be elevated. Does that make sense?
It does make sense. In terms of a metric for housing, I actually haven't heard that under conversation, and there are other social determinants of health-related metrics that have been discussed at this point. So,
but I think because there's evidence that that's why you can have a discussion about quality metrics.
Hey, I am here.
Oh, good, John. Please make this make sense.
Well, I'm not sure I can do that, but
Okay.
I'll tell you it's been discussed a lot at metrics. And, again, the metrics folks are in a metrics box. And my sense, for example, is we're further along, and in fact, there's a metric in the to-do list having to do with food insecurity. And there's been a lot of work on that food insecurity metric. My recollection is things aren't as far along in terms of housing instability or stability metric. So to some degree, this could be tied into the metric process, but there'll be some challenges to do that. I think as much as possible, it would be good to encourage that.
I guess Ray taking a stab at it. I think that there's multiple tools I think that the agency has in terms of directing some of CCO's work. One of the biggest tools is the incentive pool, and of course, focus is important, right? And there's a process in terms of setting those metrics, but that's a tool. If the board said we want you to put half the money into housing, that's something we could explore. Another tool is the community health needs assessment and community health improvement plan, which CCOs are required to do. And so where staff have been leaning is more using that as a tool in terms of directing where CCOs make their social determinants of health investments.
I want to be clear.
One comment I would make is, would it help if the statewide priority around housing was focused on children? Because one of my concerns has been this is just so big and so difficult. Would it be appropriate to start somewhere? And that would be focusing on children who don't have housing, and of course a lot of adults. Adult housing would have to be solved to a great degree to do that. But would it help? Would CCOs welcome that, or oppose that kind of focus?
David?
Well, I am all about housing. And I believe that housing is healthcare, and you can't address behavioral health integration without addressing housing. You can't address ACEs without addressing housing. I'm really excited by this, but I also want to put I want to make sure it doesn't exclude other important areas, and that you mentioned this is all about social determinants of health to get outside the member's live perspective, to move upstream and address the population. It's going to be about partnerships. I think you mentioned that. And partnerships with housing providers is going to be really important. But there's two other really key partnerships. There's partnerships with education, especially early childhood education, and partnerships with local health authorities to accomplish public health modernization. And housing is as important as education and public health modernization. I don't want to de-emphasize that, but I would be concerned about saying do something about housing and your social determinants of health box is checked, and you don't have to do anything else, because education and public health modernization are equally as important as housing. And I think to reframe as, partnerships to take care of health of the entire community, the entire population, not just member covered lives. And one of these three partnerships, should be prioritized.
And I just want to point out that in a slide coming up, we'll be talking about shared community health assessments, community health improvement plans, and the proposal is that local health, public health authorities be at that table. And then with regard to education, there is legislation that some education providers be at the CHA and CHIP development table as well. So we're going to get to that.
Yeah. Okay, great. And it's also it's really wonderful to see you get granular like this in terms of like very specific proposals and policies.
Lisa and then Carla.
I guess I want to, so I feel like taking the bigger question first, which is, should we have set statewide priorities or should we just have local priorities? I think it's important that we have sort of a statewide guideline and how those priorities get implemented be locally focused. And I'll take housing as an example. So in some areas of the state, the issue around housing is it's just unaffordable, that people can't afford their rent, right? And that's why they are not housed. In some areas of the state, it's because there's a lack of supply, that there's no actual housing to be found. So if we set a statewide priority that having your population, having the Medicaid population housed, each of the local communities then would have to figure out the best way to implement that. I also think that I'm not sure that spending a lot of time on housing recently and how the healthcare community engages in housing, I'm not sure that there's something that they could fundamentally do about some of the core crises other than be a really proactive voice in the discussion. So if we're saying we want to increase administrative costs, well, part of those social determinants of health spending fit into those administrative costs, and that would be rent. So CCO's rent subsidizing. So we're not going to decrease administrative costs, have CCO's rent subsidizing, and get the outcome we're looking for here. I also think there's a whole other question about whether CCOs are the right place to be rent subsidizing when we have other state programs that do rent subsidization for these programs that are highly underfunded currently. So is reducing our overall medical spending to put that money into other areas of the state budget where they can proactively do this, which they already do, more important to me? I think that that's a question we should have. I feel like, what's our expectation of CCOs when it comes to housing? Is it just to measure who's unhoused? That could be helpful in a lot of ways, and I think getting an accurate count of Medicaid patients who are unhoused. I also think the issue around the question about children's housing, if you ask DHS today why a lot of kids are being removed and put in foster care, it's because their parents can't find stable, affordable housing. And so we have a huge crisis in our state. I agree. The healthcare industry needs to step up and engage and proactively engage in all of the ways that government is trying to save that crisis because of the impact on them. I'm not sure that saying to them, we're going to start measuring this and holding you account, I'm not sure that they could do it.
But doesn't that make them a more effective advocate?
If we say that we're going to hold them accountable on it? I guess to me, what is the accountability here on it is my question. So if we say to CCO, let's take health share, because it's the largest CCO. It covers the metro area, which has one of the highest challenges. Or we could take Eastern Oregon, which covers Bend, which is another challenge. If you said to them tomorrow, in 5 years, 100% of your population needs to be housed, how would they get there?
Who's saying that?
That's what I'm asking, is like, this is why Carla's point is a question to me. Does it fit into metrics?
Yeah.
Does it fit? Like, I feel like the policy priorities is you're going to implement these policies to help address this issue, as opposed to a metric of you're going to measure these issues, and then we're going to have policy priorities that come later. Like, I think of it very similar to the SBIRT measurement, right? We measured SBIRT. Now we know we need to implement some policy priorities to come later because of the metric. On this issue, and I'm just talking about the housing one because this is the one we're supposed to be weighing in on. On this issue does it go to metrics where we actually are, I'm not sure right now that they could say this percent of our population is houseless or experiences unstable housing. So we put that into the metrics. And then I feel like then we would be able to consider policies and how we engage with other state agencies to implement policies that government already should and is working on implementing. Does that make sense?
It does. I mean, I think the question, correct me if I'm wrong here, but I think the question that's being asked, that was being asked by the staff and the work to date, not the one that we've been talking about in the last 15 minutes, was not, should we create a metric for housing and then what should we do from there, but was actually, should we prioritize housing at a statewide level, which means require each of whoever those CCOs will be to prioritize housing, and then what does that look like? And when I read the information, I understood that to be, you have to be able to prioritize in your planning efforts, so it needs to show up in your CHIP, it needs to show up in how you're utilizing resources, but I didn't read it as, and I think I get the question, I think it makes sense, but I didn't read it as being overly prescriptive about that. And I think, in my mind, I think if we are considering the universal call that we've heard around housing and what we know about it, it feels like the right starting point is to say, is this a priority in terms of our planning efforts and work, and not to start with a metric per se.
I agree. I just think it's important to understand that there's many reasons to do this, and part of it is because of evidence. And then when you start talking about evidence, then I think you also start talking about quality metrics and accountability. I will say that even though I think this is really important, I think this will suck up the bandwidth because it is such a big issue. And when I was down visiting in Jackson County, they have a less than 1% vacancy rate. Now, I'm not sure how you address housing in a community that has a less than 1% vacancy rate. Because if we set it as a priority, I think you also have to determine what accountability is. How do you determine if they've been successful? Is it the amount of dollars they spend? Is it like what are you going to be looking at to determine if they've actually done the work you wanted to be done when you're dealing with challenges like housing not being affordable, but frankly, no housing. There's no housing.
Right. But I wouldn't presume that then what we would be saying is Jackson County, fix your problem. 1% vacancy rate.
Then how are they going to address that?
Well, you would do it by saying, okay, how can we engage with which local affordable housing providers, granted, it's different in different communities, are going to be using money from the Oregon Community Health and Housing Services to try to build additional housing stock to slightly address part of that issue. The question is there a way for us to then align services and supports to make sure that with that population that we're increasing their stability, right? So I think part of it is a right question of like, what's the level of control that a CCO has in this situation, and then what's the level of influence that a CCO has is. And I think what we know is if we set this as a statewide priority, there's an ability for each individual local community to be able to articulate both what's that control and what's that influence, and how do we set some goals and parameters around how we want to use resources together to address some really critical issues, not to solve the problem. Maybe that's the question is, this is me speaking, I don't think our job is to say CCOs solve the problem, but I do think that we have an opportunity to say, how do we want CCOs and our healthcare system to contribute to addressing some of the issues that are really localized. So it does look really different in one community to the next, and where you're going to put that emphasis probably
needs to be really distinct. I mean, at a macro level, across the state, not just the state government, everyone's trying to figure out how you put hands on oars to try to make progress on dealing with the housing issue. And the real question is, should you all be saying to the CCOs, you belong in the boat with your hands on the oars on housing?
Yes.
Or you do or don't, it's kind of your call. And that, to me, that's really and then what, how big the oar is and how hard you pull, that ends up being a local, what's it look like in Jackson County or Portland or whatever.
And in doing so, it aligns incentives to be part of the solution to create incremental change. And there are creative things you can do even with 1% vacancy rate, whether it's shallow subsidies or matching the overhouse with the underhouse with the Airbnb models. There are creative solutions that CCOs, in partnership with community-based organizations and other partners, can row together to, we won't solve it, but we can make continuous quality improvement, incremental change from year to year by calling it out and tracking it.
I guess where I feel like I 100% agree that CCOs need to be doing something. I actually would go beyond this. The healthcare industry
yes. Mm-hmm.
has a deeply
investment.
Thank you in this issue, frankly, around housing, and have not, I think, in my opinion, stepped up in a big enough or broad enough way to address this issue, not just for the Medicaid population, but for all of those people who are sleeping in cars around parks, who have jobs and who actually make significantly more money than what it takes to qualify for Medicaid. So I feel like, but to me, I want to make sure that the policies and that if we're setting a priority, we are holding people accountable to that priority. So if housing is going to be the priority, what is the accountability that follows? Because I don't think that I want to say, this is a priority, and if you just put your name on a letter, you've done good enough. And if you just meet with because I think on some of the early learning stuff, that's what we've done. If you just meet with the early learning council, that's good enough. Good job. We're beyond that now. And when you look at the CCO outcomes and metrics, we are beyond that. So can we, if we're going to say, we all agree it's a priority, right? We all agree it's a statewide priority and the healthcare industry has a responsibility to that. Then what is it? And how do we get there and hold them accountable to it? And just putting it in their community health improvement plans in the CHIP, unless that we're going to make them responsible for holding progress on the CHIP, which we frankly haven't really done, I don't see what the difference is between us sitting here and just saying housing is a priority, you should do something about it, and what that really does.
So can we interpret that as guidance to staff that yes, there should be a statewide priority? Yes, housing ought to be on that list, but staff, you need to then go back and turn that into, and so what does that mean? What's the mechanism to assess impact or accountability, or how would that play out in terms of what we would be asking for?
And I also think it's really important on this to hear from the CCOs and the community advisory councils on where they feel like they can move the needle in their community on that, because I just fundamentally think it's such a difficult issue for them to take that piece of.
But to go back to your previous conversation, I think that we also need to hear about the other players that should be involved in this conversation. So, because if it's going to be a statewide priority, we need to hear about from the housing authority where they are and what do they feel like are the barriers or challenges, and the other groups and organizations, and that would be part of this. Because I might understand what I think the barriers are for CCOs. I don't think I understand what the barriers are for other state agencies.
So we've heard...
Which they did come actually and do a presentation, and it was mainly, we don't have enough units statewide, and we don't have enough supportive housing. Like, they should come again, I agree, but...
So in the conversations we've had with Oregon Housing Community Services, what they have said, we've heard there's not enough units on the healthcare side. And what they've heard on their side is we've got units we can bring. What we really need is the medical. We really need to bring in the medical model. We need to provide. We be really helpful if we could have CCOs provide it supported services. And so those are the types of partnerships that they would love to be able to see us be able to advance on the local level.
Because like in our community, what we were told is this, that we actually probably have sufficient housing, but it's not livable. So it needs to be renovated, it needs to be updated, but we don't have people to do that.
So I think just affirming what you said, Pat, I heard yes. I mean, I would reflect, I think, yes, we want to continue to presume a statewide priority. I think housing is the right place to do it, not exclusively. I think that's been affirmed as well. This isn't about one priority. There should be room for localized prioritization as well. I'm interested in how the MACs work on thinking about health-related services and the utilization of that to expand what we can do around housing in forms where it's not just adding to the administrative rate, but actually helps us to kind of bill effectively for this. And then the one other thing we haven't really talked about, but I just want to call out is I need a little more information about how the state health improvement plan priorities were created in order to understand whether or not we want to require that the CHPs address those. I know we've had some of that conversation, but frankly, it's clear to me how housing is something that's prioritized across the state. It's not clear to me that the state health improvement plan priorities were also generated with the same kind of collective understanding. So it'd be helpful to know that. And then I think to Felicia's point, I hope that it's clear to folks in the audience and on the, listening to this, that on each of these, it would be really important to hear where people have information and input that could inform our thinking about this, either positively or negatively, around what we're talking about. So just take that as a call out that we're in effect trying to play out some conversation that we want additional input on. And we heard earlier about what some of those mechanisms are. Jeremy, I'm just going to say there's no way in the time that we have that we're going to spend this amount of time on each of the 7 items. So I'm going to let you play traffic cop on how much time we should spend on each one, because I also think this is a really great conversation and could see value in doing that in a few key places.
I think it's more important that we have a rich conversation and get as much feedback as we can, and then to try to rush through the agenda. Some of these we can push off to August if we need to.
Okay. So if that changes your order at all, let us know.
Nope, keep plowing forward.
Probably changes the length of your August meeting.
Yes, there's that. Because then we get to do it 54 times.
With regard to that second policy option that you just touched on, the proposal that each CCO's community health improvement plan address at least 2 state health improvement plan priorities. Do you want to have that conversation now, or do you want me to come back? I mean, I can touch on. I know it's been a very public process.
It might actually be good to do that, and I mean, I think that dovetails with the last conversation. It might be good to do that.
Just to continue on right now. I don't think it'll take us.
Did you mean do it now, Jeremy?
Yes.
Okay.
So right now?
Yeah.
Okay. So I just presented with the second proposed option here is, and just to remind you all of what the current state health improvement plan priority areas are, and there will be a new SHIP by the time CCO 2.0 goes into effect, so these may change, but they're around tobacco use, obesity, oral health, alcohol and substance use, suicide, immunization rates, and communicable diseases. So there are 7 priorities right now. I do know, as I just mentioned, it was a very public process. I can't speak to it in terms of the specifics. Someone in this room may be able to, but we can get that to you.
No, that's fine.
Okay.
I think maybe that what I would say is if there are any concerns about the designation of at least 2 of those being included in the CHIPs, I'd really want to hear what those concerns are.
The one concern that I know we've heard is around not being prescriptive with regard to what the 2 are. So basically letting each CCO choose which of the SHIP priorities that they would align with. I think that's all I have in the interest of time on that one for now. So open to any feedback you have.
I guess my main question is, has anybody actually looked to see how aligned the CHIPs are with SHIP?
I know that many of the CHIPs do have overlap. I mean, and I've heard even the word most have overlap, but I can't give you the concrete number. We can absolutely do that.
We also definitely heard feedback in places where they're not aligned.
Yeah.
Through the red shop.
And was that feedback, we like our non-alignment, or was that?
Strangely, no.
Okay. Thanks.
Okay.
Did you?
I just think it's really important to clarify whether these are priorities amongst member lives or in the entire community and population, especially in terms of immunization rates. And I think that needs to be called out.
The community health improvement plans for the
is
CCOs
entire community.
are supposed to be looking
Entire-
at the entire community.
But there's a frame where that can be misinterpreted, that that population I'm dealing with is not the population of the entire population, but the population of covered lives.
It's a really good call out.
Okay.
It's a broken record I have in my pocket.
All right, should we go on to the next one?
Wasn't sure what's coming up next.
Thanks for starting us off right.
It's something simple like housing.
So the area that I am here to get some feedback around relates to one of the policies, or the policies that ask for representation of community advisory councils being in alignment with the populations that coordinated care organizations are serving in the Medicaid arena. And one area of feedback that has arisen around those types of policies within the CCO 2.0 is the collection. What it comes down to is the collection of demographic data and potentially some discomfort around collection of those types of data. So how I'd like to, I think, frame this and have us think about this is that we really need to look at what we're trying to get at with this policy and really understand and regard the complexity of the matter. Also understand that the feedback sometimes is dependent upon the assumptions that you're using when you seek the feedback. And so when we move into this with an equity and inclusion framework, I think that sometimes those assumptions may not be apparent within the conversations that are being had around this. So from an equity and inclusion perspective, we need to remember a few things, that representation, as we know, is absolutely imperative when we're talking about a public entity. We're talking about the health of people in the state of Oregon. It is critical that decision-making that's occurring and that when advice is being sought and guidance given, that we are hearing diverse voices in that, and those diverse voices are not just heard, but they're actually influencing the process. I think what this idea, these policy ideas came down to truly are, how do we attain meaningful, accessible first, and meaningful engagement of populations that are served in our Medicaid system. So once again, it's imperative that there be representation, but that is not alone the solution. So the question is not, from my perspective, if I may, is not should we continue with this policy idea, but how do we continue so that we're taking into account the complexities of the matter, the fact that we as a U.S. society do indeed still have trepidations around asking and attaining information that relates to demographics. Also that when we talk about, it's reflected here as personal information. For some people, one's demographic is very personal. For others, it may not be. So I think that we need to look at this from the standpoint of not if, but how do we proceed so that we are do have alignment and accountability around community advisory councils being representative of populations that are being served. I will stop there and ask for any clarification or comments on that matter.
So, Leanne, can you tell me what demographics you're talking about? I mean, it seems like to me this shouldn't be a very big list. So,
well, I think where we can start is from the precedent of race, ethnicity, language, and disability data. That might be the best place to begin, because that is what is being called for statewide as it relates to the Oregon Health Authority and Department of Human Services. So that's where I would begin.
And I'm assuming we have to collect this data anyway in order to determine how the CAC is going to match this, correct?
Yes, and that seems to be where the sticking point is getting this information, requesting this information, requiring this information from Community Advisory Council participants.
But if they're consumers, they've already given it.
Yes, they have.
Okay.
Not necessarily.
In race, ethnicity, language, disability.
About half of them have given.
Well, they've been.
But don't we think that's a systemic issue?
We don't know what the issue is
Okay.
around
All right.
that. And I think we need to refrain from making any conclusions about what
Okay.
the issue
All right.
is. And also, the information is also available, not necessarily in the system as it relates to individual to demographic, but through the American Community Survey, we also have information related to demographics. And the Medicaid population, right? So I don't think we need to look at Real D as in race, ethnicity, language, disability data and the issues that are occurring with those data as a barrier, because we know what the populations are and who the populations are. And we also know that we do need to look at what the barriers may be regarding race, ethnicity, language, and disability.
Can I ask a question?
No, wait, I'm sorry.
Oh, go ahead.
So I should know this, but are there size limitations on the CACs? So for example, do they say, CAC should be 12 members, 15 members? So there's not. So I guess my question is if you say your CAC membership has to match does that at some point actually decrease, somehow restrict membership on the CAC in the sense of, well, we can't find a person to keep the balance? Does that make sense?
It does, and
Okay.
I understand the question, and
Uh-huh.
and from an equity and inclusion perspective, we
Uh-huh.
can't let that get in the way of representation.
Okay.
We can't we're not talking about, okay, now we have to find one of this and one of that and one of this.
But you were asking about possible barriers, and that might be a barrier.
It could be a barrier
Okay.
depending, if we're looking at this from a standpoint of quotas, yes, it is a barrier.
Uh-huh.
But when we're looking at it from the standpoint of accessibility
Uh-huh.
and voices in terms of both voices being heard and influenced, and we're looking at it from the standpoint of meaningful engagement, that barrier then lifts. So I think what we need to do is think of this in terms of accessibility, meaningful engagement, and taking affirmative steps to diversify the CACs, and in order to do so, we do have to have a sense of the demographics of the individuals that are in the CACs and applying for. But we can't, there's no way, especially when we look at the complexities of who is represented in the state, and there's no way we can do a one-to-one. That's not the point.
And then I promised my last one.
Okay.
And how would you address the pediatric Medicaid population? Would you make sure that you had a certain number of parents that represent their kids,
I
essentially?
think those are the details that we need to work out. So once again, I don't think it's an if as much as, or should we, it's how do we do it? How do we work out these details? How do we say, yes, indeed, this representation is critical and imperative, and yes, indeed, we have underrepresentation, and now how do we adjust and change that dynamic and change the composition?
So the question for the board might not be, should we do this? And if so, despite the concerns that have been raised, what's staff's best recommendation to bring back in terms of how we make sure we have a process that best represents, the CACs best represent the community?
Lisa?
I just had a question about, I feel like the concerns have been expressed about requiring potential CAC members to disclose personal information. Is that from the CAC members, or is that from the CCOs?
Well, and this is where my understanding is that that came predominantly, and please, anyone correct me, predominantly from outreach at an outreach event that involved members from the community advisory councils. That's my understanding. If I'm incorrect, please, somebody correct me on that. And I think that also speaks to a point earlier that was made regarding feedback and input, and who is providing the feedback and who is providing the input, and how are things weighted, and what's the role of the Health Equity Committee, and how is feedback weighted in determining how we move forward.
Is there anybody from OHA in the room who's got more detail on Chris, to you?
Well, I can answer the question about this particular event. It was CAC members and then CCO staff who managed the CAC. So I can't tell who provided this specific feedback, but that was the audience in the room.
And we may not, and I think we'd have to look at feedback that we've received from the broader range of respondents, because we don't want to fall into respondent bias.
I have a question as well. Are there any situations that we know of or that we can think of where the demographics of the Medicaid members in a certain community would be completely askew or different than the overall demographics of just the community there?
Mm-hmm. Yes. Mm-hmm. Yes.
So then, have we considered like the difference between just having the CAC composition be representative of that community and not necessarily just specific within the Medicaid community?
I think that's an option, though, and I think those are the details. And what I think we need to be getting at is greater representation, accessibility, and meaningful engagement, not a one-to-one. This is that population that we need one of this type of person, another of this type of person, another of that. And from what the actual question is, the question in part is the discomfort that was expressed regarding collecting and disclosing that information. And then the other piece of that was secondary.
I appreciate the kind of making visible the complexity of the question. I trust that staff and the Health Equity Committee together can come up with some recommendations about how to resolve it without stepping back from the intent. So would look forward to hearing more about both of those perspectives. I don't want to lose on this one because I think it's the one just in the 7 that we're looking at where if I'm correct, where it pulls it out. Just the ways in which we have heard time and time again that the community members want to have greater impact and influence on CCO governance and how resources are being utilized and ensuring that that connects to the community. And I wouldn't want that to get lost just in this one important but piece of policy change. So more broadly, I want to say that I think it's really important that we're able to see through these policy options how the community advisory councils have greater connectivity with the CCO boards and governance, and that may and probably should include clarity about how many community advisory council members at a minimum need to be included in the governance process, and then some of the relationship there. And I also want to be sure that we have an opportunity to be clear with CCOs about the role of the community advisory councils not being relegated or mitigated to a singular or a small piece of the puzzle, but to have a clear influence around the way that CCO is addressing health transformation in that community. So, and I'm not sure that the policies yet get that explicit, and I do think that's a place where we can be more prescriptive. So I'm sorry to somewhat capitalize on this particular slide on a bigger issue, but I would hate for us to focus on a small piece of it and not get at the bigger challenge and opportunity that I think community has raised again and again for us, and that it looks really variably across CCOs. And part of what we're trying to do is get at some clarity about how we have consistent expectations and opportunities to support CCOs to be able to really ensure that these are community-based organizations.
I also just want to, I feel like looking at this and doing these things is we are going to do a lot of things that make people uncomfortable, and dealing with bias in any form makes people uncomfortable. And so I think I want to be clear that I'm personally fine when it comes to eliminating bias in our healthcare system if there is a general level of discomfort for quite some time, because I think that people need to sit in that discomfort because we've gotten really comfortable with all of those biases that currently exist. And so I don't actually think that we need to weigh in on people's discomfort as a policy board member. You're going to be uncomfortable, and it's going to be really hard because of that level of uncomfortable, and we're just going to move forward on it together.
might have a suggestion for staff versus a conversation here, but we passed by it a little bit on Oscar's point of what is the community that we're trying to be representative of here? Is it the larger community, which ties into David's point earlier about the shared responsibility for CCOs for population health issues, or is it the narrower community of members of the OHP? And I honestly could probably answer that question either way, and so it might be useful for the board, for staff to do a little bit of work of what would be the implications of those two choices, and come back and have a conversation about that.
I think that's a really good question, because before the Medicaid expansion, the Medicaid Oregon Health Plan had I don't know if it was the majority, but it was kids. Mm-hmm. And so if we go back, if we lose the Medicaid expansion at some point, which, hopefully that won't happen, then how does this shift? How does that representation shift, right?
She's trying to put kids on the board.
0.5.
That's what she's trying to do.
I mean, we're talking about children, right? And so when we say, it changes.
Yeah.
It would change your makeup depending on which community you choose.
Yeah.
Yeah, I think for me, the question was coming from the fact that I know that a lot of people just can't access Medicaid, or the Oregon Health Plan, so for various different reasons. But they're still part of that community, and they may not be able to access it, but their kids are probably able to access it. So we want to be able to have them be included in those voices as well.
I think it's a good question.
So I know that we're limited in time. I think it would be good if we could just get a gut check, even just on a couple more, and then we don't need to land decisions necessarily.
The 2-minute speed dating.
Yeah, right.
Can I ask a question?
Yeah.
To what degree do we know about the composition of the CCO governance group? Has any data been collected on the CCO governance group? My hope is that whatever we do makes the CACs more and more powerful. And I agree with the comments about we're going to be asking people to get into uncomfortable situations, and part of that I think will be accepting that role, and that there'll be folks interested in knowing who they are, and I personally don't think bias can be it can be reduced, but you can't eliminate it, and that your community needs to understand the bias that you bring, and that transparency is a good and healthy thing. But do we have any of this information for the CCO governance boards themselves?
Christina, we don't.
And just to confirm, you mean demographic?
You mean demographic? We know we have the
Yeah, we
names
have-
of the governing board. We don't have the
what-
demographic information, right?
But we could require that as a part of our contracts moving forward.
Good. All right, should we move on to? So let's move on to the CHAWS and CHIPS, and I think I'll just maybe cut this short and just say I think that we got a lot of feedback during the community meetings around aligning efforts, and so a pretty direct way of doing that would be require one community health assessment, community needs assessment, and one community health improvement plan between multiple CCOs if there's multiple, but also with the local public health department and with the nonprofit hospital. It might mean changing timelines a little bit to align those, or finding ways that if they're on slightly different timelines, they're still aligned as one and aren't going through multiple processes. But fundamental question, I think, for the board is that a direction that you support us moving?
And could I just add something? The proposal on the table is a shared community health assessment, but shared priorities and strategies for the community health improvement plan because of the issues with timeline and geographic area. So it wouldn't require a shared document per se, but shared strategies
But
and
a
priorities.
CCO could say, we're using the same basic information, we're tackling 1, 3, and 5, and the hospital says we're tackling 2 and 7, but we're all working together on it.
Yes.
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 I thought that's the way everybody did it.
I thought so too.
All right, that was
Okay,
easy.
that was easy.
Value-based payment then?
Yep. All right, so just as a reminder of our 3 value-based payment policy options.
I'm sorry to interrupt.
Oh,
but,
sure.
Did the letter get shared about UVP from Bruce and his group with the board?
With the, I'm trying to remember, it should have, but if it hasn't, we'll double check.
I'm just wondering if we should defer this conversation until people have had it. That was a pretty extensive written input on this very subject, and it.
Yeah,
I
we
wonder if
could.
should- No, Bruce Thompson.
I don't know if it did or not.
Loaded all comments in the CCO 2.0 public website. They're available for the board or any member review on that website.
But yeah, we can kick this to the next meeting, that's fine.
I think that might be a better
Yeah,
idea.
that makes sense.
But suffice it to say, we are continuing to push on values-based payment and understanding how we can keep moving that lever forward between now and the next time we have that conversation. Right?
Yes.
Yeah, we have to, it's in our waiver.
Yeah, it's in our
so.
waiver. It's a requirement.
That will be helpful, I think,
Yeah.
Chris, as we, for that conversation, just understanding how much of this is coming out of the roadmap work and how parties that have been involved in that have contributed to that understanding. B, what are we already required to do? So we don't need to actually have a ton of conversation about if, but more about kind of how. And then C, if there are places where where this brings up particular challenges, and we've heard some of that, what do we understand about those challenges, and either how are we mitigating that, and or how are we acknowledging it's going to make folks uncomfortable, and we're going to keep moving down a path.
Right.
Great.
Hey, this is John. Could I just make a comment?
Yeah.
If we could, when we discuss this, I think this needs to be framed in the context of the default. The default is fee for service. And I think we have to see whatever we call where we're going as an alternative to fee for service. And folks need to understand the damage that fee for service is doing to our health every day. It's a terrible payment system. And we're never explicit about that. I mean, we're trying to replace a really bad system with something better. That's all I want to say.
Thanks, John.
Variable profit?
Okay. Building on kind of the requirements of the waiver, this is also a requirement in our waiver and authority we were granted in our recent renewal. So in the 1115 waiver, we have language that talks about instituting a variable profit margin for CCOs based on their performance and cost-effective use of services. This is specifically framed related to health-related services and supports that are provided to improve how services are delivered. And improve our system and become more efficient in all aspects. So we're really seeking here, and I'll try to be brief, affirmation with the board on the focus on efficiency and cost-effective use, and creating kind of an evaluation program related to that in CCO 2.0. This is consistent with our waiver, again, to the point it's required, but the how is kind of what we're looking at, and really aligning it with the new contract, I think, is really important to setting the stage for the CCOs coming in, that efficiency is really important to us. The how they get to an efficient place and the evaluation of that program is really kind of the ongoing process. And I kind of equate this to the quality pool for CCO 1.0, where we created a structure and it evolved over time, and us looking at efficiency and improvements in potentially integration, reductions in readmissions or inefficient care or system waste. Those are things that we should be tracking, and CCOs are tracking them on their own with provider contracting, but this really gives us a lever to reward the performance of some of those CCOs with variable profit. And one of the pieces, just to kind of, I think someone mentioned it a little bit ago, but really looking at the idea of premium slide, and as we try to reduce or not do as much medical cost, this gives us a lever to potentially reward the CCOs that are creating other supports and services that make our system more efficient without having to kind of see their costs or their revenues decrease in the same way. It's not a one-to-one, but that was the intent. So really just looking for feedback and kind of the affirmation on this requirement.
So a couple clarifying questions.
Of course.
Are we required to provide an opportunity for variable profit through our waiver, or were we given the option to provide, or given the latitude to provide a variable profit mechanism?
I think it's a shall.
I think it's a shall.
The decision point really, if you have feedback and if you don't, that's fine, is, should this just be sort of wide open to any type of efficiency, or do we really want to hone in on health-related services and use this as a tool to say, if a CCO is making investments in health-related services that are showing up somewhere else, that's a priority in terms of how we design this versus just any type of efficiency.
Okay.
It's a shall without an implementation deadline, I think.
Right, exactly. Timing is not specified in the waiver.
Okay.
Can you clarify what is health-related services?
I have a couple other questions.
Oh, I'm sorry, but if we're going to talk about health-related services, I'd like to know what that means.
Yeah, you should ask that question, but I just had a couple more that I
Okay.
want to ask. I'm just doing what you did to Felicia.
I know. Don't mention health-related services.
So, can you define?
Yeah.
Can you define variable profit? We're talking about for-profit and not-profit organizations. As the actuary in the house.
Oh, I'm not an actuary.
Oh, okay.
But actuarial translator maybe. No, I think that in how we build the rate setting, there's the medical portion, or kind of your traditional Medicaid services component of the rate, and then a profit is part of the non-benefit load. So we build, that would include administrative cost, profit, and risk contingency are bucketed together. You could say that's helping to make sure they have adequate reserves and really can handle fluctuation. And then the last component we have it included is case management and health-related services items as well. So really non-benefit load is a percentage on top that's evaluated based on the CCO's financials and administrative costs that they provide. But currently in our rates, we have a 1% profit load, and that's 1% off that medical component. It's not necessarily to say that they're going to make 1% profit in that year, but it's really just kind of a requirement in how you define
So it's a
actual.
function. It's a function of the resources available in the next year based on the resources used in the current year. So through the rate setting process.
In the non-benefit load in total, yes, and the profit load is really more of just a standard 1% right now. But if there was,
But we're moving to a variable rate.
Exactly. So the idea would be that would vary based on the performance and efficiency the CCO would perform in that year or the previous year.
And would you define, you used the term premium slide?
Yeah. So the idea in the waiver and how it was framed was that as you spend less on medical services and really create more supports, your rate would reduce, or you would have this premium slide and you get less money in the future. And I think that's something that we hear a lot, is if you spend less, you get less. And really having this additional variable option in the rate helps us address that with a real quantitative and evaluation behind it of real efficiency. And I think this also gets to one of our pieces that we talked about from the waiver evaluation, is how do we compare CCOs and compare performance. And that's one of our intentions as well with this, is really to look at efficiency and give more, as much as we can, in apples to apples about what is being provided across in the performance of each CCO. And I think that was difficult in the past because the quality pool really focuses on specific quality measures, and it does have some efficiency components to it, but looking at it more holistically in the next waiver will help with kind of that transparency and comparability.
So last question.
Yeah.
So in terms that would make sense to me,
Yeah.
Tell me if this is right. We know that we are trying to create more opportunity for CCOs to spend on non-medical,
Right.
Without having it negatively affect their rates in the future, assuming that spend is supporting things that matter in the system.
Mhm.
And the question that we already know that's going to happen because that's the shall. The question, as Jeremy said, that you guys are putting forward is, should we focus that on health-related services as a means to kind of access that variability?
Mhm.
Is that correct?
Yeah, health-related services are non-medical benefit services that improve health and outcomes.
So that's the air conditioner.
Correct.
Okay.
Yeah.
What about housing?
Yes.
Yeah.
Can be.
Non-medical.
Right.
Correct.
Even though housing's covered in it.
Yeah, I think a good example in the rule is that there's specific open-ended to preventing readmissions or something like that. So housing supports out of a hospital discharge, I think would potentially fall under health-related services based on that interpretation. But to your point, I think, yes, we're looking for kind of the focus and how all-encompassing. I would add one thing, that health-related services, how that impacts the efficiency of the medical program, making sure that that's really holistically involved. I think that's where we're looking for some direction.
So I would say yes, and that it would be great to hear input if people have reasons why that's not a good idea, particularly. But I would also say that to Carla's question, for us, the MAC, the Medicaid Advisory Committee, just did a pretty extensive report on what health-related services are, what they can and can't be used for, and how you define that, and that may be helpful for us to understand as we get to yes or no on this ultimately.
So under here, you say incentivize healthcare services with highest clinical value. So are you talking about medical services, or are you talking about health-related services?
We include both of these policies on here because they do interrelate. The way that we've been thinking about evaluating efficiency is both from a medical and a health-related services lens. And this really does talk about the medical side of things, meaning are they providing the highest value services for the members available. And that could relate to having good health-related services, meaning good peer supports, good navigators around to help them get to the right places versus going to the ERs or something that isn't the best or the highest quality care. So I think there's ways you can intertwine all of those together. Does that make sense?
So, and
Yeah, and I know time is.
I'm wondering if we should bring this back instead as a more clear staff recommendation on how we would suggest approaching it for feedback at the next time.
I think what might be helpful actually is Jeff puts on those webinars that sort of explain the issue before. It would be helpful for me to have one of those webinars on this. They could be. I know that Jeff is like not doing the whole webinar.
I had the.
I know that. He sent the email to me that's like, hey, get on this webinar. Hey, here's the follow-up PowerPoint of this webinar. So
I will say,
in my mind.
I did get a chance to talk to staff about this previously, and I asked some of the same questions, partly because like I needed a deeper dive, and it was really helpful. So I think just giving the board members a little bit more, because a lot of this is frankly language that we don't really use.
Right.
So.
Right. Yeah, I would be happy to do that.
And it seems like we don't have an option to do this because we already said to the federal government we're going to do it. So
it's more what we emphasize in the design.
Exactly. Yeah.
So with only 10 minutes left, I know there's the last agenda item of the draft report. I think we can probably take that offline. And I'm wondering, since Mike's been patiently sitting there for an hour, if we spend just the last couple minutes on behavioral health. And I think the question really, frankly, is moving forward, we've got a whole list of behavioral health policy options. A lot of them are pretty process focused, and I think there's a decision point, or at least some input that would be really helpful in terms of how prescriptive do we want to be in terms of telling CCOs how the behavioral health services should be organized or shaped or controlled by them versus being more outcome focused in terms of what do we want to see on the ground. And Mike, you can clean up my mess that I probably didn't outline that correctly.
I have a light on mine. So anyway, yes, that is the gist of it. It is, and more specifically, we brought the benefit together, physical health care, dental, and behavioral health, but we still are working behavioral health as somewhat of a siloed benefit, and we're looking, a lot of the policy options will rest on the accountability of the CCO in moving things forward in behavioral health. So how do we do that? For example, there was some feedback that we received is, one, get rid of carve-outs. So that would be real specific. We kind of somehow put in language to say eliminate carve-outs. You can't do contracts in a certain way. We don't believe that that specific kind of recommendation is the best way of going. But we're really looking at how do you hold the CCO accountable across for the total benefit, which includes behavioral health. You know, how are the budgets managed, and is there, you know, shared savings across those budgets? How are they managing the networks across those physical health care and behavioral health? And so really, how much do we focus on outcomes versus how much do we provide guidance in regards to processes and things they should have in place to move the needle?
And we sort of started this in January, I think, with a feeling or a lot of feedback from the board that we really need to get clear on what integration looked like. And I think throughout the last couple of months I've gotten more feedback of maybe it's a little bit less important to be focused on defining integration and making it look the same everywhere, and a little bit more important to be focused on outcomes that would reflect people getting the right care at the right time.
I think with that said, though, and I was sharing with Jeremy, is just that the clinic I work at works with 2 different CCOs, and their behavioral health processes are completely different. And so I think especially in areas where you have shared CCOs, when you focus on outcomes, it could be your numbers are not going to be high enough to be able to really make a sense of whether, if that outcome is valid or not. Which then I think gets back to the point of what is it that you're really trying to accomplish, and if it's you're trying to accomplish, you know, care right away with the right person at the right time, then that's a process. That's not an outcome necessarily. And so, so I think that's part of the integration discussion is process also. So personally, I think at where we're at right now with behavioral health, frankly, it has to focus. I think it has to focus on process because I don't feel like we're at a place yet where we can look at outcomes, to be honest with you.
I've got a question that probably has more to do with how we administer this than a policy question. And what I'm wondering is when we say delegation, it almost sounds like what we actually mean is not delegating so much as seating, right? This is no longer the CCO's responsibility, it's you, community mental health organization's responsibility, and so if there's a problem, OHA, don't call me, call them. Yeah. Is that what the contracts actually say, or do the contracts actually talk about delegation, in which case I would expect, much like I delegate rulemaking authority to various people in the agency, I expect legislators will call me when they're ticked off?
Yeah, I know that there is, and there may be other people with more specific Medicaid knowledge. There are some guidance regarding, I'm not sure if it's in our waiver or contract regarding how much you can delegate, and there are limitations on the delegation. But then it goes further as far as how you define that, as you were saying.
Okay. I think this one gives me a lot of pause because on the one hand, I think we don't have the luxury of just saying it's too complex, let's kick it down the road. Like it's really clear that this is a significant and urgent issue that's impacting individuals and communities in significant ways. It feels a lot like there's a lot of like, my way is the right way. If I could just do it my way, then it'd be fine. And yet nobody really wants to have the kind of authorization or authority to, so there's this a lot of kind of both pushing off and so on some hand, it's like, well, yeah, it should be about integration. It's about getting everybody in a room together and kind of, but that clearly isn't. So I'm just getting it like on the one hand, it's a really complex issue. On the other hand, we've got some urgency here. I liked your distinction between delegation and seating, like that, like getting like peeling it back a little bit more to understand what the issues are feels important. And I don't have a good solution to this, but I feel like we as a policy board want to be able to be explicit about the expectations that we are going to, as a community, make real improvements in our behavioral health delivery system. That the voices of consumers have to be kind of at the center of that equation and issue, because it's a lot of different issues depending on who you're talking to. And that CCOs and local mental health authorities both have a real responsibility to help to contribute to what that solution looks like. what that actually means and how we set it up in the process so that we can adaptively address that problem or those problems over the course of the next 5 years is a question I'd kick back to staff to say we need more clarity about that. But I don't think we want to over legislate the solution on the front end when it's so complicated, but we also don't want to say, let's study this for 5 more years while things continue to just degrade. So I don't know if that's helpful, but it feels like we need to be both clear and we need to be adaptive and responsive over the next period of time to be able to really address the issues.
In the roadshow, you had a very clear statement that people want real-time, on-demand access to mental health and substance use services, which is a very simple, straightforward thing that makes a lot of sense. And I think I agree with you, but I think there are some things some standards that we could set.
So maybe it's moving back to that, the outcome.
Mm-hmm.
And then getting clear about what process we want to see.
We know that there's wait lists, there's a lack of access to providers. People are not getting, not being able to navigate the system.
I think there's outcome and then clarity about who is going to be held accountable for achieving the outcome. I think you got to do both.
Right.
Well, and my impression is right now CCOs are required to contract with certain entities, and as a result, I don't think that they necessarily feel like they have a lot of leeway of how to put certain processes in place.
Required to contract with whom?
The community mental health agencies.
I can think of at least one example where they don't do that.
Yeah, there's been at least one where they've switched.
Yes, Jackson County switched.
Because they couldn't come to an agreement, is what I was
Yeah.
told, and so
But
I
if you
assume
can
they
get
got some kind of
agreement,
waiver.
right, yeah.
So in the CCO statute, in setting up the CCO, there is a requirement that there is a written agreement between the community mental health program and the CCO. In that language also is explicit. It doesn't dictate that the CCO is obligated to contract with the community mental health program. So there are things around, crisis services, for example, that really makes sense for that to happen, but there is not a mandate that they have to contract with CMH.
And they reached an agreement in Jackson County with the county commission to contract with someone else. It wasn't just that they did it.
With the 30 seconds we have, what do you need from us, Jeremy, to get clear about what we need here?
Nothing. Maybe.
So glad he looked your direction.
Yeah. Maybe some more time between now and August, as folks have time to engage with us and give us more thoughts as we're digging into some of this offline.
Can I ask I feel like on the transformation center side that's done some work on this behavioral and the behavioral health outcomes, but also helping have the CCOs meet their current obligations around metrics and scoring and change their processes to meet things. What was more helpful? Was it the process metrics or was it the outcome metrics that were more helpful?
When you say more helpful, do you mean more helpful at the CCO level with regard to changing their behavior? Well, I mean, my understanding is, and I defer to Mike here, that the CCO incentive metrics are outcomes based at this point.
They're all
Is that-
outcomes based.
Yeah, so I could say other things about the technical assistance we provided, but I don't think it's relevant to your question.
So I think I would lean towards, more outcome-based than if what we've learned is that moves the direction much faster than process-based.
It also feels like in other areas, we've gotten more prescriptive input and feedback, and maybe we have here, and I'm just losing it in the midst. So one would be either in the comments that we've received and or in the committee work that's been done, including the collaborative, are there some clear recommendations and prescriptions? And if so, I'd like to be able to see those a little bit more clearly and then understand the ways that staff has either incorporated those into the proposals and or has not, and what the rationale is around not doing it. That may get us more toward, and I think your point is right, David. If we know what if the outcome can be that clear, which felt right, I thought when I saw it as well, and if we know some of what the right steps are for addressing some of the reasons why that currently isn't the case, can we just call those out and get clear about that?
We may need some expertise, because I mean, on-demand access to medication, not only just substance use treatment, but medication-assisted treatment, would be sort of a higher level of care, which would be, I think, a very desirable outcome. But we're getting into sort of, a defined area of expertise in terms of what is the gold standard.
Well, I think if there's anything else that folks need between now and August, please suggested a webinar. Let me know. Feel free to reach out if there's areas that you just need a deeper dive. I think going forward, a lot of the feedback that we heard on the roadshow is probably going to be kind of our primary lens in terms of what we're starting to bring back to you in August. So as you're thinking about that, if you have other preferences or thoughts or suggestions, feel free to reach out.
The one other thing, Jeremy, that I think in terms of the prioritization process, how those two columns around relative effort and relative impact influence the prioritization process that you all think about internally in terms of the capacity that either OHA has and or the capacity that the system has will be helpful. I didn't read any of those as saying don't do these. I read some as I think either we have to do them and or we should do them in order to get the kind of change we want. And then there were a number in there where it was more where there was more nuance around kind of what the proposal was. Great, we've reached our full time. Thanks all. I know we could have had really deep conversation with each one of these, and that's only 7 of the 54. So we'll be back here on August 7th from 8:30 at least to 12, and if it's longer, we'll let you know.
It's only 6 of them. Yeah.